Good morning to everyone in person and on Zoom. I think our camera is somewhere over there. Thank you. I'm honored to welcome you to our 2024 Veteran Health Conference, a gathering dedicated to addressing the unique health concerns of American veterans. First, a warm welcome to all the veterans, caregivers, advocates, and healthcare professionals attending. Your dedication to improving veterans' health is truly commendable. Veterans face a range of health conditions, including PTSD, chronic pain, and suicide risk, which profoundly impact quality of life and well-being. Getting an accurate diagnosis and finding effective treatments are often significant challenges. These health concerns require specialized and coordinated medical expertise, thoughtful consideration of someone's unique life experiences and circumstances, and an unwavering dedication to improving care. Today's conference aims to be a valuable resource for supporting veterans' health and increasing awareness. Throughout the day, our speakers will share groundbreaking research, clinical advancements, and personal stories. In addition to gaining insight, please take this opportunity to connect with each other. There is immense strength in community, and by learning from one another, we can better tackle the challenges ahead. In closing, I'd like to thank each of you for your presence here today. Thank you to the team of staff who put an enormous amount of effort into planning over the past few months. And thank you to our advisory board members for your critical guidance along the way. Together, we can make significant strides in improving veterans' health. Thank you.
Okay, our first speaker today is Dr. Victoria Powell. She will be presenting on psychedelic assisted therapy. Victoria is a clinical assistant professor in geriatric and palliative medicine at Michigan Medicine. Her research focuses on the impact of psychosocial stressors, chronic pain, and opioid use on physical and mental functioning in older adults and people with serious illness. Please welcome Dr. Victoria Powell.
Hi. So no conflicts of interest. We'll be discussing off-label use of drugs for sure, though. So in today's talk, I'll just be giving a very broad overview about how psychedelics might work, what are some special considerations for veterans, and then share some information about some ongoing and upcoming clinical research in veterans. So just briefly in general, what are the current thoughts about how psychedelics might work? So again, a very broad overview. Hopefully it'll give you a sense of why psychedelics have been tested in so many conditions: PTSD, depression, alcohol use disorder, and more. Now, there, just to kind of, what exactly is a psychedelic, just so we can all get on the same page. So here's a few examples. There are dozens of them, maybe even hundreds, but these are the three that are probably the most well-studied right now. Psilocybin is a natural compound found in several kinds of mushrooms. The mushrooms have been used by indigenous people in Central and South America for hundreds or maybe thousands of years. Ketamine is a drug that's been used for over 40 years for anesthesia, sedation, pain relief. But in the last decade or so, last couple decades, it's been used for depression, where it can be effective even when standard treatments have failed. So it's the only psychedelic agent, although whether it's a psychedelic is sometimes a little controversial, it's the only one that's legally available in the US. Now, MDMA is a drug that was first tested around the 1970s. It was made in a lab by making certain chemical changes to amphetamine or speed. So it does have a stimulant-like quality. It also produces very intense feelings of closeness, improved mood. Now, all of these three, just as examples, because they're all pretty different, they have different actions in the brain. They work on different pathways to some extent. And what they have in common is that they can produce a mystical experience, which might be the best way to define what a psychedelic is. Now, what is a mystical experience? These are natural phenomena that occur in some people, not involving substances at all. They've been documented across cultures, often in a religious or a spiritual context. For example, people having prophecies, shamans. The qualities that they seem to share are that a feeling of a sense of unity accompanied by feelings of reverence, a deeply felt positive mood, and then just a feeling that it's hard or impossible to really put the experience into words. There's also a sense of kind of encountering some sort of absolute truth or kind of some accessing something that wasn't accessible before. So now in describing this, I want to be clear, I'm not suggesting that anything supernatural is actually happening. These are simply qualities of mystical experiences that mystical experiences share, and participants report some or all of these under the influence of psychedelics. Now, there seems to be something special about going through a mystical experience, and we think that this might be one of the ways that psychedelics may help for a variety of conditions. So here's one possible way that this could look over time. So the psychedelic medicine produces a mystical experience, and then after the drug itself is worn off, there seems to be this period of increased flexibility and openness. And during that time, the patient might be able to reframe challenging situations in a way that they might not have been able to access before. And this might lead to improvements in symptoms like depression, for example, that's long lasting or maybe even permanent. Hopefully, that kind of gives you just a broad sense of how they might be effective for many different mental health conditions. The state of being more flexible, being more open could help with many different types of struggles. Now, while on their own, psychedelics may be helpful, most studies are looking at psychedelics in combination with some type of psychotherapy or talk therapy. And usually that focuses on one or more sessions preparing somebody before the psychedelic experience. And then during that period of increased flexibility and openness soon after the experience, working on integrating that and really helping someone make sense of what happened in the context of their life and their particular struggles. So the idea is that hopefully with the assistance of an expert, a therapist, or a guide, the person can receive more benefit than they would just from the psychedelic alone. So moving now into a few special considerations for veterans. So about 2 years ago, the VA released a review of the evidence of clinical trials of psychedelics with a focus on veterans. And they also outlined in this report, it's several hundred pages long, what further research needs to be done. And because this is such a fast moving field, this document is already out of date. And I'll give you some updates what's happened since then. What I want to emphasize is that the VA is really listening and understands that these medications do have the potential to help veterans struggling with a variety of mental health challenges. So here's just a broad summary. This is the major findings of the report. So they did think that MDMA assisted therapy, so MDMA plus some type of talk therapy may help with PTSD, and psilocybin assisted therapy may help with depression and alcohol use disorder. But most clinical trials were not focused on veterans or even included them at all. And they felt the strength of the evidence really was considered low. So they really, they said it's promising, but we need to know a little bit more. So what's happened since then? So since that was published in 2022, not very long ago, but there's been some important updates. So in 2023, there was a very large clinical trial that was published that compared MDMA-assisted therapy with placebo plus therapy for PTSD. And so here you can see, I hope you can see in the graph of the study that there are two groups. The red line is the MDMA group and the blue line is the placebo group. You can see kind of they start at that same level of severity. So the lines are intersected there at baseline, and lower scores is better. Lower means less PTSD, fewer PTSD symptoms. Now, while both of them started off around the same spot, the MDMA group improved significantly more. 86% of the folks in the MDMA group got better versus about 69% in the placebo group. So that was pretty exciting, and kind of made people think, well, maybe this is actually going to get FDA approved for PTSD, and we're going to have another treatment available for these folks that are really going through it and maybe some of the other treatments haven't worked. Unfortunately, several participants in the earlier MDMA clinical trials started to speak out about the way they were treated by the therapist while they were under the influence of MDMA. Some of them reported feeling taken advantage of when they were very vulnerable. It's a very vulnerable state to be under the influence of a psychedelic. For example, there was a lot of physical contact and stuff that just was not professional behavior. So this is a still from a video recording of a participant in one of the MDMA trials. I wouldn't show something like this if it weren't released by the participant to the media. She felt like she had been harmed during the study by the therapist, and she wanted to share her experience as a warning to others. Both of these therapists were then barred from participating in any other clinical trials, but this was overall really concerning to hear. Then earlier this year, over the summer, the FDA recently did not approve MDMA-assisted treatment for PTSD based on the evidence from an expert panel. There were several reasons for this. And the first, was the reports of the inappropriate therapist behavior. And so when the FDA reviewers dug deeper, they really felt that the therapy part of the treatment was not well described or standardized. And ultimately, the FDA panel just didn't feel that there was enough information to be able to tell the effects of the MDMA from the effects of the therapy. They didn't feel that the study data was collected in a way that would be expected to understand that the benefits of the treatment outweighed the risks, especially because of the concerns that some of the participants raised during the sessions when they felt very vulnerable and some of them felt taken advantage of. And then after the FDA rejected the request for approval, a scientific journal then retracted several earlier studies because of concerns about unethical conduct during the trials. And so, many veterans, other people dealing with PTSD were hopeful that this was going to be a groundbreaking treatment, and it was very disappointing. Now, I want to be clear, the FDA didn't say that it didn't work. They just felt that more evidence was needed to really say that the benefits of this outweigh the possible harms. Now I want to share some information about what the VA is doing to promote clinical research in psychedelics, including a little bit about a study that's going to be happening at the Ann Arbor VA location within the next year or so. So in recognition of the need for better treatments for veterans struggling with just very common mental health conditions, PTSD, substance use disorders, depression, the VA is currently funding studies in this area. So as of February of this year, there were at least 3 clinical trials looking at MDMA-assisted therapy in some form, different VA sites. I don't think any of them were in Michigan, and at least 1 study of psilocybin-assisted therapy for PTSD. Ketamine, IV ketamine, intravenous ketamine, and then S-ketamine intranasal. It's a nasal spray treatment for depression, is already available at many VA hospitals, including Ann Arbor. A recent study found that IV ketamine treatments helped half of veterans with severe depression that was resistant to other treatments. And half might not sound that impressive, but to get to ketamine being available, you really have to have very, very severe depression. You have to have multiple different trials of different treatments that all failed the patient before moving into ketamine. So the fact that about half of these folks were really, really helped by ketamine was really nothing. It's quite remarkable. It can be a very effective treatment for treatment-resistant depression. So these are some, I think it's always nice to hear from the people that actually experienced it, because I think it really gives you a sense. And I wish we had more time where I could just, we could watch some videos of people kind of sharing what they experienced. It's really quite meaningful and profound. These were not studies in veterans, but they kind of, I think the themes are similar. So for treatment-resistant depression, these patients received ketamine treatment. I felt like I was able to deal with the issues in a self-nurturing way, just that I accepted all the stuff that happened. It's not the end of the world. I don't need to hate myself over things I haven't done right. And you can kind of see in these quotes, like how that openness, how that flexibility might manifest for someone who's maybe struggling with depression. It's changed the way I perceive my own brain and the way I experience reality in a more realistic way. So there are also several studies investigating ketamine-assisted treatment for various conditions in veterans. And one example, there's a small clinical trial that'll be starting at the Ann Arbor VA probably within about a year. It's going to be focused on veterans who are dealing with both chronic low back pain and depression. So we'll be investigating how we might improve the benefits of ketamine for veterans dealing with both of these. You know, we know chronic low back pain, it's the most common pain condition in veterans. It causes a lot of disability. Depression commonly co-occurs. It's not hard to imagine how someone dealing with chronic pain can also, become depressed, or maybe the depression is related to the pain. It's kind of a chicken or egg, but it really ultimately doesn't matter because they're very commonly co-occurring. And when they co-occur, it seems to be harder to treat both. The standard treatments just don't seem to work quite as well. Now, we know ketamine has pain relieving effects from its use in anesthesia and antidepressant effects, but unfortunately on its own, it just doesn't last very long. It lasts, for some people, it lasts a few days, other people up to a few weeks at most. And we really want to see what we can do to make it last longer. How can we maximize those benefits that people are getting? So this upcoming study, just to give you a sense of one example of studies that are ongoing, will involve receiving a series of 4 IV ketamine treatments, which we hope will result in that period of time where people's thoughts become more flexible and open. The hope is that following up those ketamine treatments with a new integrative treatment program that's in development would result in longer lasting improvements in both pain and mood. And happy to take any questions if I can answer them. Happy to entertain them. Thank you. Yeah. Side effects oh, she asked what are the side effects? Side effects of is there a particular one, or just psychedelics in general? Yeah, it's kind of the things that may make it effective can also be side effects. Some people find it's an experience that's impossible to describe, and if you can't describe it, it's really hard to prepare somebody for that. Some people have very disturbing feelings or thoughts that come up, and could potentially be traumatizing if they weren't adequately prepared or not in a right place where they're safe. And I think that was one of the concerns of some of these participants in the MDMA studies, where they were very vulnerable. They were in there because they had PTSD. So I mean, they were struggling already, and then they underwent this experience where they were kind of thrown out of their element in just the craziest way possible. And then the therapists were touching them excessively. It was that those are the vulnerability probably under the influence it's a side effect, and it also may be part of how it works. A lot of these, MDMA is a stimulant. Remember, it was derived from amphetamine. So it does cause increases in heart rate and blood pressure. Most people, even people with, high blood pressure that's controlled with medications, most people do okay with it. But there's the possibility that if, that somebody might not do okay with it. Ketamine also causes increases in heart rate and blood pressure. Psilocybin too, it's kind of it's a stressful thing to go through. Not all stress is bad, but it certainly does stress the body somewhat. So we want to make sure that people are, that their medical conditions are under control before getting into one of these studies or trying one of these compounds. Oh, yes.
To the medical field for upcoming medical students that are becoming practitioners?
The question was, is this being taught in medical education essentially? I am not sure. I kind of doubt it. I kind of doubt that we're getting a whole lot with I'm not involved in education at the medical student level, but I would doubt that there's a whole lot being taught formally about it. It may be taught, ketamine may be taught because it's becoming really standard of care for depression, especially cases of severe depression. But I'm not sure. I think, probably not so much until these receive FDA approval. Oh, please, add, Dr. Boehnke can definitely add more.
I mean, cannabis is just much more legal at the state level, throughout the country, very similar, there's just like a huge lack
Mhm.
of appropriate education for healthcare providers at all different levels. So psychedelics are poised to follow in the same path as cannabis,
Mhm.
but they're far behind it.
Mhm.
Can you summarize what he said?
Oh, that's similar to psychedelics, cannabis also, there's just really a lack of knowledge and education for healthcare professionals. Fortunately, hopefully that will change one day, but I think you had a question, right?
Get involved in the studies, specifically for the psilocybin.
Yeah, so that please you can feel free to share these slides, and there's actually a link that to a VA website where it's focused on PTSD. I'm not aware that there's like a central repository of studies for veterans specifically, but on the VA website they do link to the specific clinical trials for psilocybin for PTSD. And actually there, if you go to clinicaltrials.gov, that has it's not very easy to search, but that does have all of the different clinical trials that are ongoing in the US. It's kind of a requirement that they all be registered and the results reported. You can search by, you know, the compound being investigated, the conditions being investigated. It's not the most user friendly though, but it is available, and it's you can publicly search it. Mhm. Oh, yes.
Question, and this may be apple and oranges, I don't know if it's related. What's the difference between the marijuana, cannabis
Uh-huh.
versus the psychedelic? Because we know that some people, they take the medical marijuana for pain
Uh-huh.
and some for mental relaxation.
Right.
So can you tell me, can we compare the two, or they're two separate things? Does that make sense?
It does make sense. So kind of the question is how is marijuana or cannabis, is it a psychedelic, and or how does it compare to a psychedelic? How is it different than a psychedelic? And I guess I would say it's kind of a philosophical question in a lot of ways. You know, some people might say that cannabis is a psychedelic agent, but I would say I think maybe the difference is that most of the time, if it's just cannabis, it's probably not going to have the ability to induce a mystical experience in the way that some of those other, you know, people can describe the feeling of being under the influence of cannabis. You know, it doesn't have that quality of, you just can't say, you know, what this was or really even put it into words. It really doesn't seem to produce that feeling of accessing some sort of ultimate truth. And it's just a little bit different, but it certainly does have very powerful effects on the mind and the body for sure.
We have a question coming on Zoom. Why isn't acid included in this?
Oh yes. So you know, I said there were dozens or maybe even hundreds of these, and acid or LSD, you know, that is absolutely a psychedelic. There are some clinical trials that look at LSD assisted therapy, but that it's not quite as commonly studied. Probably the reason for that is that it's harder to do those studies because the effects of LSD last a really long time. They would require, you know, if you think of how would a clinical trial be done, you would have to be with someone for probably 12 hours or more during the experience of LSD. And that's probably not that it doesn't have the same potential that psilocybin does, but probably for practical reasons, it's just been studied less commonly. I wish I could kind of list out all of them. There are many, but these are the three probably the most commonly studied right now. Thank you.
So just a couple of notes for our speakers going forward while Riley gets the next slides up. Because of our live transcriptionist, if you could try to speak a little slower, not slow, but so she can kind of keep up with the typing of what you're saying. And also, we don't have a speaker projecting into the room. So if you can speak a little louder so the folks in the back can hear, that would be fantastic. And also, like when someone in the room comments, the transcriber cannot hear those comments coming from the room. So if you're a presenter, can you just try to remember, and you did great, Victoria, to reiterate those questions so that everyone can catch that. Alrighty, our next speaker is, we're gonna hear from Christina Mariani and Katrina Beshears. They are going to speak to us about the intersection of pain and suicide prevention for veterans. Christina and Katrina are both licensed clinical and macro social workers at the Detroit Veterans, Health Administration as community engagement and partnership coordinators in suicide prevention. Please welcome Christina and Katrina.
Hello. Thank you all for having us. I'm Christina and this is Katrina. Katrina has lost her voice, so she's here to support me and interrupt me when she has a thought, but it'll mostly be me speaking. And we're so grateful to be here. Thank you for having us. We are just up the road at the Detroit Medical Center, if y'all are familiar. Yeah, we're so glad to be here. We're from suicide prevention. This will be, like we said, an overlap of suicide prevention and pain. And so we can get started. So we have a quick disclaimer slide before we do get started. Of course, suicide is an intense topic. We talk about this regularly, but not everybody does. And we want to recognize that. So if you know, sometimes it can surprise us when we feel a reaction to something that we're learning about or hearing about. So if you need to take a break, please do. We mentioned the bathrooms are down the hallway, or if you just want to step into the hallway, go grab a snack at the back, whatever helps you feel grounded and safe. Please do that. And we have our Veterans Crisis Line. You all might be familiar with 988. If you press 1, it is for veterans and service members. If you don't press 1, it's for everybody. So please utilize that as well as sharing it with your people when necessary. Any questions before we get started? Great. Thank you. And really quick, I know we met some folks earlier at the table. Can we just get a raise of hands of who is a veteran in the room who served in the military? Oh, lovely. Great. Thank you. It's awesome. And maybe also who's a family member or a loved one of a veteran. Great. So Katrina and I did not serve, but we come from long lines of service members. We're both younger sisters of veterans. So it's very close to us to talk and learn about this together. Okay. So we do have some general statistics, and you all might be familiar since you all live and work in this space. But we know that veterans are at an increased risk for both pain and for suicide. And so when we talk about risk in general and how to intervene on that risk, and our risk is overlapped in different ways, it's good to keep this in mind that there's just a higher chance and a higher severity of these experiences in our vets and service members. We also have the statistic as many as 50 veterans registered at VA experience chronic pain, and this is across gender. We talk a lot about gender differences in VA because there's a gap in that. But so this can be a lot of different things. We know pain can come and go. We know there's different levels of severity of pain. So but about 50% are experience chronic pain. And we also know that even separate from being a veteran, folks with chronic pain also have an increased risk for suicide. So I know some of these overlaps get a little bit confusing when we talk about it, but we want to reiterate that the risk is there, and to be cautious of it when we're looking for it in ourselves and the people that we work with, the people that we care about in our lives, and to be aware of that there. Okay. So we also know, and this is of course what's been reported, so we don't know what hasn't been reported, but about 9% of the people who have died by suicide also have chronic pain. So this is separate from veterans. This is all Americans. So that's what was reported, like in the either, verbally or in their healthcare, that they've had that prior to their suicide. And we also know that people with moderate or severe pain are 3 times more likely to have suicidal ideation and 2 to 3 times more likely to die by suicide. So again, this is talking about the prevalence and the likelihood of this happening. And it's something I think, when we talk about chronic pain or pain at all, this isn't, maybe the first conversation that we have with our loved ones when we find out that they have some kind of pain. But it is something to be aware of, that they might also be struggling, or that it might be at minimum a thought that comes into their brain. People with chronic pain who die by suicide also have a comorbid medical or mental health condition. So this makes sense, that there would be, these diagnoses that follow along with the pain and the suicide ideation and behaviors. But these are good things for us to know, and to look out for when we, either find out about one or the other in ourselves or our loved ones. Anything? Sorry. Okay. Can y'all hear me? Okay, great. Okay, so risk and protective factors. So we're not doing our usual like suicide prevention 101 training today. But when we do, we often talk about what to look out for in our people and ourselves, and what might put somebody at an increased risk for suicide right off the bat, even, from day one, the situation that you're born into. And so those are our risk factors. Those are the things that, set us off maybe a step behind, or that might make that more likely for us to either feel suicidal or act on those behaviors. And again, you might recognize that some of these are related to chronic pain in general. Our physical health are related to these. Another thing that I like to mention is that these are often things that we don't have any control over. Unfortunately, these are things that happen to us, things that we might not even be aware of if we're born into it. And then later we find out like, oh yeah, I am part of that group, right? In order to balance this out, we want to increase our protective factors as much as possible. So these are the things that balance out that risk, that give us a little bit of padding so that when we're having a bad day, we have things to fall back on. And that can kind of bolster our quality of life and our sense of self. These can also be related to pain and physical health. These are also related to our support systems a lot of times, and things that we can cultivate in our lives to feel connected to our surroundings and to ourselves and to our support network. So that's the goal, is to minimize the risk as much as possible and boost the protective factors. Okay. So this is our interpersonal theory of suicides. There's a couple of different theories that people talk about when we do research in suicide. And this is one of the most common, most longest used theory. Are people familiar with this? Have y'all seen this before? Okay, so some nods, some shakes, that's good. And so you can see how it kind of comes together. So the idea is that the combination of these things can lead to a suicidal behavior attempt ideation. And it's simplified so that it can be utilized by most everybody. So the idea is a loss of belongingness, inability to feel a sense of belonging and connectedness to our surroundings and to ourselves. And the combination of perceived burdensomeness, sorry. And this is an interesting one. So we don't often even, so you might hear somebody say like, I feel like a burden, right? I feel like I'm, leeching on my people. Or alternatively, unfortunately, we might also feel like somebody is a burden to us, which is an awful feeling to feel, but it is something that we experience as humans and often at times as caretakers or as healthcare professionals. So the combination of these things, the loneliness, a sense of isolation, a sense of nobody knows how I'm feeling, nobody understands me, And the combination of that and feeling like a burden or feeling like a burden can be is oftentimes a starting place or one of the things that we see in people who also report suicidal behaviors and tendencies. Our hopelessness, so this is closely related, and you can maybe see why. I feel like there's no way out. I feel like there's no options. I can't see a future. There's no light at the end of this tunnel. And that is also an awful place to be. Nobody wants to notice those feelings within themselves or hear their loved ones say things like this, but it might be something that we've heard in our suicidal patients, but also probably in our pain patients, right? Even if you haven't heard it, you can maybe picture it, right? Like I've like literally definition of chronic pain is that it's always going to be there. So feeling like there isn't any hope for that or like there's no way out is a really yeah, you can see the tough place that it puts people in of feeling trapped or feeling there are no options. And then the combination of those things with a suicidal desire, the want to kill themselves, and the combination of that with the ability to kill themselves, some kind of lethal means, a plan, and a general maybe familiarity with death. A lot of times we talk about that in the military too, but maybe also in healthcare, right? If you're around death, talk about death a lot. It doesn't have the same sting as to maybe the rest of the world, the rest of civilians. And it's much more normalized in our beliefs and in the way that we move through the world. And so there's less of a fear associated with that. And it doesn't feel as far of a stretch to us maybe. So these are the combination of things that often lead to suicide. And again, we can see the layers here of how this might intersect with some of our pain folks, either in ourselves or our patients. And then I put some of the things on the bottom there, feeling trapped, lack of options, lack of control, not having a sense of control or like I can make decisions for myself in the situation. It's just happening to me. The being acquainted with death and lack of fear associated with death. We also heard earlier this week, there was a presentation that somebody did and the way that he phrased it was really helpful to me. So this can be, and I found it similar for pain as well, a sense of feeling, what was it? By your body. It wasn't abandoned. Betrayed by your body. And this can be, thank you. This is, you know, when our service members have served, whether it's deployment or not, there might be a sense of like, I've depended on my body and I feel like I've taken care of it. And it's betraying me. It's no longer doing what it told me it would do, right? You're not holding up your end of the deal. And that can also go for our minds and our, you know, our consciousness, right? You're betraying me. And we have this long ongoing relationship with each other. And I don't feel like my body's holding up its end of the deal. So we can also maybe associate that with pain, even, you know, with, you know, lots of experiences. If we get injured, surgery, you know, there are lots of things that can be associated with this. So just another thing that I thought was helpful. Anything on this before we move on? Oh, sorry. Yes.
It's making the point that something is happening to me that I don't want to happen.
Mm-hmm.
And as a military sexual trauma survivor, that's point is poignant, and I appreciate you having the language to articulate that. Having the language to articulate that is part of controlling the trigger.
Yeah. Thank you. And thank you for making that parallel too. So the comment was relating the sense of feeling that something is happening to me that I don't want to happen in a military sexual trauma experience. So this is something that we see a lot, and the lack of control, and that, right, that feeling of like, I'm not an active participant in this and it's happening to me, and the acceptance that has to come with that, which is painful, and right, working through the triggers, and being able to gain a new sense of control following that experience is a deep challenge for a lot of our folks. And again, when we're looking at the overlapping risk of all of these things, if you layer a sexual trauma experience on top of that, right, you can see how things pile up really quickly. And the spiral can happen quick too. Thank you so much for that. Okay. So one of the ways that VA, and thank you so much to our speaker earlier speaking about our VA research. Another one of the ways that VA has worked towards our pain folks, but also for our mental health folks, is our whole health clinic that we're very proud of. And we're really working to expand. We have one at Detroit VA. So this is meant to help the whole person, body, mind, soul, and our sense of self. And we talk a lot about this in relation to, substance use recovery, general mental health recovery. We talked a little bit about PTSD today already. And also our chronic pain. We know that these treatments and options can also work for our chronic pain. And this is meant to help us feel some of that connectedness when we were talking about feeling the sense of feeling belonging and feeling isolated, right? This can help us even within ourselves to feel that we are there for ourselves, which is a challenge and a lifelong journey. But that is one of the goals. And this is, of course, a very human experience, a human alternative or way to approach these experiences and these symptoms. And this, of course, we always recommend that this is paired with or we want all of our departments to be working together, right? So if your primary care, helps take care of your blood pressure, we can also meditate for blood pressure, right? All of these things work together in harmony, hopefully, to help us to achieve our goals and what we're looking for to help us feel better and have more of a say in what's going on in our lives. And so these are some of the things that we have specifically at VA. We have these at Detroit VA. I can't speak for all VAs, but I'm willing to bet that most of them have these things. And so chiropractic care, acupuncture. We specifically have battlefield acupuncture too, which is really interesting. But we also have acupuncture specifically for pain management. Massage, medications, and psychotherapy. You all might be familiar with CBT for pain. There are other psychotherapy options as well. And like I said, our medications working hand in hand with some of these options to work together as well. Trying to think if there's anything else. So no, fine. Okay. So if you are interested in these things, and you haven't yet accessed them at your VA, you can ask your primary care, you can ask your mental health, and there's a consultation that they can put in the computer and get you sent over to the whole health clinic. And they're all lovely people. We work with them. They're sweet as pie. So helpful. If you like pie. Okay. All right. And then this is just some of our VA resources and information. It might be a little bit small to see up there. But we have our individual and group psychotherapy options. I mentioned primary care. We have the general mental health clinic. We have specialty care clinics. Our primary care also has a mental health integration program. So it's kind of like a stepped care in between primary care and general mental health. There's like an in-between that can help with a lot of different things. They can do a lot of ongoing care there. We have our chaplain services, also part of that whole health component. They help with all different faiths, exploring faith. Also really wonderful folks there. We have telehealth options, which you are probably all familiar now that we're, acquainted with some telehealth and Zoom things. Our vet centers. So we have our vet centers at these locations. Vet centers are cool because their documentation is separate from the medical center. So so it's all therapy options. It can be for couples, for families, and it's all for our combat vets. And so if somebody is private, of course, about their experiences and their healthcare, they don't want their notes overlapping with their primary care. It's a separate documentation system. It was created by our Vietnam vets back in the day when trust was not there for very obvious and clear, good reasons. And so they were created back then to give a safe space. So we still have those today. And then our Michigan Veterans Affairs Agency is our state agency, which is separate from our national program, but they also have their own funding and great programs. And we work very closely with them. And so that information is up there too. Great. Any questions? Yes. Or comments? Oh,
Yeah,
great.
so we
Okay.
have a question in
Mhm.
Zoom. What kind of stuff do VA mental health people tell you if you have suicidal ideation?
Okay. So the question was, what kind of stuff do VA mental health people tell you if you have suicidal ideation? Okay, great. So if this is a good question, because a lot of times it's like, tell somebody if you're suicidal, and then you don't know what actually happens after you tell somebody, and it can be a little scary, especially like on one of your worst days. And this is also true when you call 988. So if you call 988 and you tell somebody that you're suicidal, what are they going to do after I say that? So questions usually follow, are you suicidal? If yes, remember we were talking about that, like access to lethal means. You have something that you would use to hurt yourself. Do you have a plan of what you would do? Are you actually going to do it? Which seems like an interesting question, but you can maybe think about it like, oh, well, I want to go to China, but are you actually going to go? Like, are you making plans to do this? Like, do you intend to do it? So similar thought process. Are you going to do this? Is there an intent to do it? And depending on your answers to those questions, there is the option of just like a general referral to treatment, whatever you are agreeable to. If it's, a specific need, like, oh, well, I'm homeless and so that's why I'm feeling this way. Okay, can we get you homeless help? And then there is, of course, the more severe side of things, depending on how extreme the circumstances, there can be emergency help deployed to you to get an ambulance to get you to the hospital, to the emergency room, where they'll ask you similar questions. And you might, there's the PET insert process, the petition and certification process to be admitted into the hospital. So that is, of course, like I said, farther along on the end. The idea is to get to folks prior to needing that, right? If we can prevent from getting to that point, we can implement things prior to hospitalization, then ideally we don't ever get there. But yes, those are the options. Yes.
There are victim suicide safety plans online, or do you have one with you?
Yes, we can get it to you. I don't know if it should be on the website. But if it's not, we can get it to you. We can share that with the folks here, but we can also email it to you. We have a blank one. Sorry, let me repeat. Suicide safety plan. It's a blank form of, step-by-step things that you can write down. It's meant to be personalized of like, when I'm having a bad day, what are things that I can do to help myself feel better? And take steps either within myself, my immediate surroundings, or reaching out for help to get me to a more stable place. It's good to have on deck, like an emergency contact kind of a thing. But yeah, we can get that for you.
We have another question in the Zoom.
Mhm.
What do VA doctors tell you if you have chronic pain causing suicidal ideation?
That's a good question. And I'm not a veteran. I haven't told a doctor that so maybe does somebody have an experience of what? Yeah. Yes.
I don't have experience as a veteran.
Yeah.
I work in a pain clinic in a VA
Uh-huh.
with my pain doctor.
Okay.
So depending upon which VA you are in,
Yeah.
if you're in Ann Arbor VA, we do have pain psychologists embedded. So a part of the VA's movement towards addressing suicidal ideation is creating more access. So we have clinicians in oncology clinic, women's health, and pain clinics.
Mhm.
So what would happen is they would do what's called a warm handoff, and the doctor would say, hey, we have a veteran who's having a hard time. Literally stop everything that we're doing and we will come to you
Mhm.
and we will have that conversation and go through those same questions.
Yeah.
are you suicidal, what's happening, kind of get an understanding.
Mhm.
It may turn into a consult or pain psychology where we talk about those things that have to do with pain that's leading to those suicidal ideations.
Mhm.
Or it may turn into a visit to the emergency room if things are beyond that we can control with
Right.
the outpatient.
Okay, great, thank you. So I'll try to repeat it. Just tell me if I.
Oh, sorry.
No, you're fine. Thank you. So also within, someone was speaking from one of the Ann Arbor clinics, and also within Detroit, all of our departments have folks embedded into the team to help with these situations. So if somebody were to say this, report this in any clinic, right, even if it's audiology, whatever, there are somebody that we can call in to have a conversation and evaluate a little bit more closely, talk through it a little bit more and see where we're at. So it's meant to, and our folks know that they can pull on a mental health or a designated person to help through that conversation. That also happens regularly within our teams. And again, some problem solving, what can we do right now to help with this, ask some more questions, and then if to get those referrals and assistance. And if it's outside of that realm of control, then we'll seek emergency help. Great, thank you. Yes. Any other questions? Yeah. Yes. Yes, no, thank you. Yeah, so we have a one pack or trifold in the back that's about Compact Act. It's separate from Pact Act, if that's something that you all are familiar with. So Compact Act is for mental health specifically, for suicidal crises. If somebody has a suicidal behavior attempt, their care associated with that attempt can be covered by VA, even if they're not otherwise eligible for VA care is the key. If your discharge status stops you from receiving VA care or otherwise, you can still receive these benefits. There's other details and other eligibility built into it, but we have some information on that in the back. Katrina gives the example, like say if someone slits their wrist and they need emergency care, they will get their inpatient care, their follow-up care, any wound care associated with it, antibiotics that you might need, that would all fall under the Compact Act. So that's also a good resource for folks to be aware of.
So we decided to put mental health patients that are having their mental health therapy or whatever in the community, stop their community and bring them back. I don't know how to say it. I don't think that's a fire room. Those are things stopping patients in the middle of their health treatment, their mental health treatment to come back to VA.
Yeah.
Or in appointment and things.
Yeah.
But I know we strongly
Yeah. Yeah, thank you. I want to be cautious of the time, so this will be our last question, but thank you so much. It's a good question. We get it often. So question was about our community care process. So right now, VA will often has referred out in the past to community agencies that are also adequate to provide care when we don't have the staffing or somebody is far away from the medical center, so get something closer to them. So it's been community care for a while, and more recently, those cases have been reviewed more strictly, and it's been we're trying to bring folks back into the VA system, and so community care has been decreased, more limited, more restricted. And the question was a concern for the mental health of folks whose care is being interrupted, whether it's mental health care that they're being sent to the community for, or physical health care. You can also. Okay. Okay. So the concern is for the mental status of folks whose care is being interrupted. And And yes, absolutely. So this is something that we're also concerned about and that we've heard a lot about. And we also have relationships with some of these agencies, which has been a positive thing, you know, for ongoing care, that we've been able to have these relationships and communicate about the flow of information and resources. But yeah, it's absolutely a concern. And, you know, especially when we talk about like a lot of mental health diagnoses and treatment, a sense of consistency and being reliable is like really foundational, and can be challenging then to say, by the way, we're shifting your care, and you've, you know, built these relationships, and so we're it's going to be different now is a challenge, and something that we can appreciate. We also we have designated people at the VA to handle some of these situations. I also want to say they're also still up for review. It's just that they're being like more strict about the review process, but we still encourage folks to advocate for their situation and explain why it is that they receive community care. It's not that it's being stopped completely. So there is still space there. And we also have people at the VA who are patient advocates and our liaisons for different departments that are handling some of these requests and also advocating on behalf of our veterans. They're documenting these experiences and complaints. You know, we know the VA has a long process for a lot of things, but we the more that we document experiences like this, the more that we're able to report them up the chain of command. But yes, and it is a national issue, which is so it's not, I don't want folks to feel targeted.
Not site specific.
Yeah, not site specific. Yeah. So, but yes, we realize we're recognizing the issue, and it's unfortunate. Thank you all so much.
The recording's already going.
All right, if we can make our way back to our seats, we're gonna resume here.
You ready to talk about weed?
Thanks, Brian.
Let's do it.
Brian's obviously been in the military and he's got that projecting voice for me here. Okay, so our next speaker here is Brian Hanna. He's going to give us an update on the cannabis industry in Michigan. He is the executive director of Michigan's Cannabis Regulatory Agency. He previously served as a criminal intelligence manager with the Michigan State Police, a deputy sheriff for Kalamazoo County, and a captain in the U.S. Army Reserve with a combat deployment to Afghanistan from 2010 to 2011. Please welcome Brian.
Thank you very much. Glad to be here, and thank you for your attention this morning on a Saturday. Let's talk about weed, right? Who'd have thought? I have a 25-minute presentation that I can literally talk about cannabis and all of the intricacies of regulating it and the challenges of having something that's legal at the state level, but illegal at the federal level. I could talk for weeks. So the whole point is I'm really condensing where our intersections are with veterans and how our program works, but you can find further information at our website, and I'll say it a couple of times. Also, it's great to see some folks that we've been working with studies, helping with some things we'll talk about in person. It's been great seeing people over Zoom. It's also great to connect in person. So thank you for having me. All right. Long story short, our agency is responsible for regulating 4 statutes in the state of Michigan. Marijuana really got started in the regulatory path in Michigan in 2008. And that created the patient and caregiver program that we still have today. That started with the Michigan Medical Marijuana Act That act has not changed at all since 2008. Why? It requires 3/4 vote in legislature to amend that act. Some of the acts in which that we are responsible for regulating have a 3/4 vote threshold in legislature, which means it's very difficult to get changes because you need serious bipartisan support. So that started the patient and caregiver program in the state of Michigan. What that really is a confidential program in which somebody can have a doctor certification to get either a patient card or a caregiver card for other patients in the state of Michigan. You can have a certain number of plants and you can have a certain amount of product for your medical condition that is approved via the act. What ended up happening is businesses started to open in the state of Michigan between 2008 and 2015. Where you had your business depended on whether you were A, successful, or B, went to prison. So there was unequal enforcement in the state of Michigan, which then led to the Michigan Medical Marijuana Facilities Licensing Act, MMFLA. We like acronyms, right? Government. The Medical Act for the facilities started in 2016. We issued our first license in 2018 for the medical businesses. And then when we're figuring that out, I was part of that effort, one of the very first members of the regulatory agency. Adult use came online. And so now we have adult use businesses. We issued our first adult use marijuana business in November of 2019. We now have over 4,500 marijuana business licenses in the state of Michigan that we are responsible for regulating. We're also responsible for a small piece of the Industrial Hemp Research Development Act. Long story short there, we are responsible for the hemp products in the state of Michigan. And we need serious law changes to that act. We're working with Representative McKinney out of Detroit. Thank goodness for him. We're working hand in hand. He's going to drop a bill package any day to regulate hemp products, and I'll talk about some of that in the next few slides. But what's also important is to note when it comes to the registered patients and caregivers in the state of Michigan, we are not unlike any other state that regulates cannabis. When you have an adult use program, your medical programs start to drop in participation. Why? Because some people feel there's more access on the adult use side. I no longer need my card, but that doesn't mean the program's going away. There are those that still want to have that patient card, that patient status, and the confidentiality requirements that come with that status. One of the big questions I get is, Brian, why is there no list of patients and caregivers that I can access in the state of Michigan? I'll tell you, it's against the law. In fact, if my staff publish a list, we can be charged with a misdemeanor. Since I don't want my staff to go to jail or myself, we follow the law, which is our job. The only people that we can actually give the patient caregiver information to is law enforcement. But the point of this slide is there are still 84,000 registered patients in the state of Michigan that need access to their medicine via this program. There's also a tax incentive. When you have this card, you're not charged the 10% excise tax at a marijuana business as opposed to when you have that certification. Okay, let's talk about veterans in our intersection. There are some things that we have to do in accordance with law with veterans in the cannabis regulatory program. There's also some things that we created that we felt it was the right thing to do. And again, I'm a veteran. I bring in that background. And I've been the director since 2022. One of the first few days I was there is what else can we do for the veteran community and the cross pathways for the business community when it comes to cannabis in Michigan. So we created some pretty common sense initiatives. So we have for marijuana businesses, we recognize those that are veterans that own marijuana businesses in the state of Michigan. So if the majority ownership are veterans in the state of Michigan, we recognize them through the Veterans Recognition Program. So that customers, veterans, anybody can know this business is owned by veterans. They have a seal that we created, and we have a list on our website. I'm going to plug this shamelessly throughout my presentation. michigan.gov/CRA. And we have a veterans recognition program for those businesses that are veterans. But we took it a step further. And again, this is the VRP. Ownership structures provided to us. They apply, very simple. They send in a form and they get that recognition. We put it on our website and they can put something right on their business. But we took it a step further. We thought, we know there are marijuana businesses in the state of Michigan that can provide free product or heavily discounted product to veterans. And we knew they were already doing it. So we wanted to consolidate that, bring it to our website, and create a new program called Task Force 1620. Now, I'll admit I created that. 1620, it's 420 in military time. You know, try to keep it a little bit fun, but it's something that veterans will get. They know what a task force is. They know what military time is. It's something that speaks to veterans from a veteran. Task Force 1620. And what that is licensees who implement a veteran access program that offers cannabis to a veteran at 75 to 100% discounted rate are eligible to participate in this program. And so we make this available again on our website and at the businesses, that there are marijuana businesses that will give this heavily discounted product to veterans. It's up to the business on how much, how often, what percentage of disability would they do for their program. But it's a step forward of bringing veterans and marijuana together that we already know there's a relationship. And I'll get into some of the challenges of that relationship between state and federal governments here in the next few slides. Okay. All right. What we also have is something that is in accordance with the law. Now, the Adult Use Act, MRTMA, very long, 2018 citizen initiated, also requires 3/4 vote in the legislature to amend, has in it a requirement of us to provide $40 million for, quote, one or more development and research projects, including clinical trials that are approved by the United States Food and Drug Administration and sponsored by a nonprofit organization or researcher within an academic institution, researching the efficacy of marijuana in treating the medical condition and preventing the suicide of United States Armed Services members. Veterans, excuse me. And so we're proud to partner with 3 separate, can I get this to work? There we go, got it to work. 3 separate combination of universities and a place called the Multidisciplinary Association for Psychedelic Studies, MAPS. And through grants and through basically a bid process, all available on our website. And we have members that are doing this research that's incredibly, incredibly valuable and needed right now. We have MAPS, Wayne State University, and University of Michigan all doing these studies in accordance with the grants, in accordance with the law. And so we have that money earmarked for these studies. And we're excited to partner with the universities and MAPS that are doing these studies. We also acknowledge the challenges they experience to be able to do clinical trials of marijuana with veterans while it's a Schedule I substance at the federal level. Go back, and I'll talk about some of the more specific possibilities there could be with rescheduling and descheduling, and I'll get into that in the next few slides. But besides of the really great work, spearheading work that they're doing for clinical trials between the efficacy of marijuana and preventing veteran suicide and how important that is, it's also challenged. It's challenged because they have to get that FDA approval and also the DEA approval to do those studies. And to do that with marijuana product when it's Schedule I is not an easy thing to do at all. In fact, we have regular quarterly meetings with University of Michigan, Wayne State University, and MAPS to figure out on their progress of how they're doing with their research. And some of the challenges they deal with I'll just give you an example, is acquiring the product. Believe it or not, those that are doing clinical trials cannot just go to a marijuana dispensary or retailer and grab the product and use it for their studies. It has to be properly sourced through a DEA source. So we have these 4,500 licenses that are all over the state. I'm sure you've seen the billboards. I regulate that too. Thank you. There are challenges to research. And so that really goes into what I'm going to talk about next with rescheduling and descheduling. Just want to say we're also a gold star veteran friendly through the MVA employer. And what that really means is if somebody applies with us and we have a lot of positions continuously opening up, we want to bring in veterans and apply. And we want to have veterans show up for an interview. And that means if veterans apply for our positions, they do have an extra status where we take an extra look at their application so that we can give them a chance at an interview. We have a lot of veterans working in our agency, not just me. And so we're proud to be recognized by the MVA. Talk about employees. We have a record number 38,000 employees in the marijuana industry. There are job opportunities for veterans, not just at the state level, but also at the businesses as well. And then current issues. Again, I can spend 2 days talking about these things. When I mentioned the hemp laws that we really need to change, the bottom line is the 2018 Farm Bill really opened up Pandora's box to these hemp products that are all over the United States of America right now, most of which are not regulated. In fact, if you know kids, they can get on the internet right now and order these hemp products. They say hemp on them, but they'll get you high. We have got to fix that. We're working with Rep. McKinney to do that in the state of Michigan to bring in the regulatory responsibility that we need to do on those CBD THC converted products and THCA products. Just think of those as hemp-derived products. But they're also getting the marijuana industry too. And so there has to be clarification and more regulatory responsibility needed with changes of laws. MCT oil, believe it or not, you can eat MCT oil. You're not supposed to breathe it. And people were putting it into vape cartridges in the regulated market and unregulated market. Regulated market, we fixed that. We add that to a required testing requirement, make sure that there is no MCT oil in a vape cartridge on the shelves for people. Products that are there right now, we have open investigations, recalls are pending. Believe it or not, marijuana businesses are not paying each other. That's a symptom of what is happening when you have something that's legal at the state level and not the federal level. And so when I get into non-payment, we're trying to address those with new rules and all the things I just barely touched on. But we have new rules coming out very soon for the marijuana businesses. We're going to have public comment on those. We want the product to be safer for consumption. We also want to save businesses money. When something made sense in 2018, it doesn't make sense in 2024. Why spend the money to do it? And then rescheduling and descheduling. The bottom line is this. We know that there's a possibility that the federal government may reschedule marijuana to Schedule 3. If anybody comes to you and says, that's great, here's what's going to happen, I would recommend you go, really? Because if anybody tells you they know what's going to happen, they don't know. They don't. We wrote a 9-page memo on our website, michigan.gov/CRA. You can see our response to the federal government. It's basically 9 pages of saying, what are you doing? Because Schedule 3 is where Vicodin and codeine live. There's no adult use Vicodin and codeine program. So we already know that our adult use programs would still be federally legal. Did you know our medical programs are not FDA compliant? They would still be federally legal. What does that mean for banking? What does that mean for safe access? What does that mean for social equity programs? What does that mean for transportation of marijuana product? Did you know that every state has different labeling and testing standards? What does it mean for unifying those if we're going to have product go across state borders? A lot of questions, no answers. Now, descheduling is a whole different bag. At the end of the day, all I can say is this. We have very little federal support because of its status of where it is at the federal government. But do we have some lines of communication with folks at the FDA? We do. But we rely on each other as cannabis regulators. We have a Cannabis Regulators Association where we talk to each other as a national resource until we get online with the feds, if there's any change to the federal level. And then we have a cannabis reference laboratory that's incredibly, incredibly needed and under construction right now. And that is to bring in the testing standards of the marijuana product that through the regulated environment in Michigan. If you regulate cannabis, you need one of these. We're lucky to be one of the ones that are about to have one online. Bottom line is, we have a lot of information, a lot of intersection with veterans, but here's our website. You feel free to go to at any time. And with that, I'll take any questions. Sir. Thank you.
After leaving the military, I went to work as a paramedic in Texas. 2015, they enacted a compassionate use program.
Yeah.
Are you familiar with that at all?
No.
So a lot of first responders and law enforcement to use THC. You had to go through a doctor. And basically, when you came up through your analysis, that was omitted through on the urinalysis test. With federally, it's still federally legal in Texas. People are still going to jail for marijuana. Fast forward to 6 years, I come up here to a legal state.
Yeah.
And there's no such protections in place.
Right.
Has there been any talk about possibly having like a medical use program for first responders in the state at all?
Right. So we got a question basically summarized in Texas. There in 2015, there is a law in which protects first responders and certain people from having risk of losing their job or going to jail if they use THC products. And what is Michigan doing about it? So what Michigan has is every state is different. Every state has different laws, different rules. What Michigan has done so far is expunged low-level crimes for possession of marijuana. We have, as a state employer, stopped drug testing new hires to the state of Michigan, unless, of course, you're under a certain category of employment. Law enforcement, not of that category. They still have to be drug tested. Those that are under MDOT, Department of Transportation, that also have federal stances, are not protected when it comes to the drug testing. Believe it or not, Cannabis Regulatory Agency, we're going to have a reference lab. Our staff in the reference lab will be drug tested because they'll have access to the product. I tried civil service rules. I have to follow them. My point is this: every state's different. Are there talks? Are there conversations? There are. But the challenge is, anytime that you want to talk about change or regulatory reform of the human being of using these products, it's also tied to federal funds of some other agency, right? And then law enforcement typically in the United States will defer to federal law when it comes to what their staff can and can't do. My point is this: I'm not aware of anything specifically to protect people that are first responders if they use THC in Michigan yet. I have seen some progress, though, when it came to some people not having to be drug tested. But my point is this: when you see federal change, then you're going to see a trickle-down effect of what that federal change may be for what the states may do. No problem.
We have a question on Zoom.
Sure.
What do you do about the side effects of cannabis?
So as a regulator, it is our responsibility to take in any kind of feedback in which somebody had a negative side effect to a product. Now, we take the stance of, then we try to trace down, was that product compliantly made? Was that product tampered with? We do investigations from that perspective. But is it in line with what is typical with, for example, Health and Human Services? No, it's not. We're not there yet. We don't have all of the necessary, I'd say, reporting mechanisms online with each other. Let's say somebody goes to the ER that got a product and it immediately feeds into our database. We're just not there because A, it's so new, and because of the disparity of federal and local. I will tell you this: we've had conversations with the Health and Human Services. We've had conversations with National Poison Control Centers. Part of the problem with the industrial hemp problem is if somebody goes to the emergency room or has negative side effects, it is very hard and confusing for that medical professional to understand whether that came from the regulated market, what market it came from, was it tested, what was it tested for? Because there's a plethora of unregulated products out there that mimic the regulated ones. What we have right now is Wild West with the industrial hemp products. We want to bring that in and hopefully we can have more of a congruity of having a better understanding of the side effects. Looks like I was told time's up, but I got more questions. Real quick. Yes. Yes.
If a product is compliantly made.
Good question. On regulated product, there is a plethora of required things that have to be on the label. A metric identification number, the date it was tested, where it was tested, all of that information. Now, does that necessarily mean that there wasn't shenanigans that happened during the supply chain? If a consumer has a suspicious of that product, we do the investigation as the regulator. Okay, all we have time for. Thank you very much. Thank you. Appreciate it.
Okay, next we are going to learn about pain management for veterans from Thiera Clifford. Dr. Thiera Clifford. And she is a pain psychologist at the LTC. Charles S. Kettles, VAMC, VA Ann Arbor Healthcare System, and clinical assistant professor at the University of Michigan Medical School Department of Psychiatry. Please welcome Dr. Clifford.
Hello, everyone. It is a pleasure to be here. What I'd like for you to get today about payment. Thought I was being loud. Look at me. A part of what I'd like for you to get today is what it would look like to gain pain management within the VA healthcare system and some of the things that we look at and how to gain access. Okay, so a specific overview of some of the pain challenges that veterans face. We're going to talk about some of the complexities as it relates to pain management in veterans, review both of those physical and psychological treatment options, and then highlight a few of the programs and resources and integrative care approaches that we've been approaching in our VA and specifically at the Ann Arbor VA. So first things first, this is something that we talk about a lot. It's some of the physical origins of pain. So we think about chronic pain in veterans, oftentimes it's musculoskeletal, wow, it's so hard today, injuries from maybe active duty service or some type of combat-related trauma and its lasting effects. We do know that there are other things, if there were things that happen maybe in basic training. I've had people get injured well before they're deployed. We know that it happens and we deal with that as well. Some of the psychological things that can help, that can impact pain perception. So the influence of PTSD and other trauma and pain processing, things that may happen, depression, co-occurring mental health disorders, anxiety, insomnia, and things of the sorts. So all of these things can truly impact how we navigate when we address your pain as a veteran in our system. And so some of the physical approaches to pain management. Oftentimes, these physical approaches are what we like to call passive pain management approaches. When we think about what is a passive pain management approach, you are not necessarily doing anything to receive that pain management. So things like opioid medication, NSAIDs, other alternative medications, they come with a lot of benefits. Of course, we know that opioid medication, it works, but there are also a lot of risks and side effects that come along as well. And so oftentimes one of the things that we see within the VA system is that our system is moving away from the use of opioid medication, and we're giving these other alternative options and other pain medications, and they don't work as well at first. It does take time. It's a hard sell, we know that, but we ask that you help us and work together so we can figure out what that looks like. Because what we found is that when we are using these more passive types of approaches to our pain management, when you're working with your provider to say, okay, this is working, this is not working, we can find a good shift. We all know that chronic pain is so complex, it's often a symptom and the disorder. So we need to figure out what it looks like for you. So something that may work for you may not work for the next veteran and vice versa. Other things that we do within our system, so things like physical therapy and rehab, so exercise, doing programs such as the MOVE program. It's one program that a lot of veterans tend to find very helpful, especially if they have health and nutrition goals. You do not have to do it in group format. For a lot of people, they're like, I don't want to be in a group. I don't want to do this. It is offered individually. I know I can say that for sure within an Ann Arbor setting. I can't speak on behalf of the John D. Dingle VA, but I'm sure there's always a way to make an accommodation. Again, we are here to service you and to help you navigate through your experiences and not do it alone. So being able to advocate for yourself and say, hey, I'd like to do this. However, I'd like to do this individually is one thing that I have seen, and it's been very beneficial. Manual therapy. So physical therapy. A lot of people don't like to go to physical therapy. I'm hurt. I don't want to do something that's going to make it hurt worse. But we are more afraid of you not moving and things getting stiff and worsening over time and creating more disability. And that's where we start to think about that cycle of chronic pain, where you have a chronic pain and you start to withdraw because it hurts to do, and it leads to some emotional responses. Oh, I can't really get into it. My emotions are all over the place. You start to avoid things, and that leads to more disability, and that disability and moving away from it adds to more chronic pain. And we got to get out of that cycle. So it's really important that, yes, it does hurt, but after a while, it does get better. There's a difference between soreness and pain and injury pain. So hurt versus harm. We have to really think about that. Also, when we think about physical therapists are able to offer certain alternative types of approaches to your pain management. So things like H-Wave, the TENS unit, and being able to do alpha stem. Oftentimes you can do, I know we mentioned battlefield acupuncture. If you're not familiar with that, because a lot of people are like, I'm not having needles all over the place, right? Battlefield acupuncture is a little bit less aggressive as a full body acupuncture. They do it in the ear. And it's just cute little buttons. It's needles, but cute little buttons, and they fall out over time. But it tends to be helpful for those who have tried it. Another thing, we do have chiropractic care. In my particular clinic, we are all embedded. So I am literally in the clinic, and we work together as a team and as a unit. The thing about chiropractic care, for a lot of people, it may not necessarily be an option based on what is going with you physiologically. It's not that they don't want to do it, but sometimes manual manipulation can make things more complex. It could actually cause more injury. But they also have things like massage and things of that nature. Now, some of the pros, of course, of this being a more personalized treatment is that it's designed specifically for you. These are things that, you know it works for you. This is something that we can do. Some of the cons sometimes is that it takes time to get to it. We know that when we're dealing with our providers, one VA is one VA. So if you're coming from a different VA and you're used to getting in and getting out and things happening very quickly, you get to a different VA and they're like, okay, that'll be 3 weeks out. You're like, I'm sorry, what? So we ask for your patience. Please speak up. Please ask questions. Okay, well, if there's a cancellation, is there another provider that is available? Don't be afraid to ask those questions. Oftentimes, especially when you do have other specialized mental health professionals within your clinic, we can also serve as the advocate, because we can ask those questions, say, hey, I see this consult went in last week, but there hasn't been any action. Can you give me an update on that so I can let my veteran know what's going on? So please use us to your advantage. Now, for my favorite part, which is the more psychological approaches to pain management, which is what we would like to call the more active. These are therapeutic techniques that you are going to do a lot of the work alongside with your provider. So when we think about some of these techniques, in particular, what we do in our clinic, we do a lot of the CBT for chronic pain, which is the cognitive behavioral therapy for chronic pain. We do acceptance and commitment therapy for chronic pain. We also do emotional awareness and expression therapy within the chronic pain clinic. Now, within these therapeutic techniques, this is often come by way of a referral from your provider. It does not have to come from your pain provider. It can come from your primary care. Sometimes your first contact with a pain provider may be through PCMHI, which is our primary care mental health integration program. They can do a brief version of the CBT for chronic pain. It's usually 6 sessions, about 30 minutes. And I always suggest that as a veteran, if you're ever wondering, like, I don't really know how to feel about these interventions, I don't know if it's going to work, I think that's a good way to be introduced to what therapeutic work for your pain looks like. In particular, with those 6 sessions, they go over what we like to call a pain consult. So there's an initial, that first session is all about learning about you and your pain, what you do, what you don't do, how it works, how it doesn't work. And then from there, we work through okay, what are some of the pleasurable activities? What are things that you enjoy doing? We teach skills such as pacing. So oftentimes, and this comes up a lot with my veterans, because a part of how you were trained was you don't stop until the mission is done. That's a mentality that you just don't get rid of when you become a civilian and come home, which means that if you're doing yard work and your back is hurting and it's been 30 minutes and your back has been screaming for the last 25, you're going to keep going for that next hour and a half and then wake up tomorrow and say, oh my gosh, my pain is through the roof. I don't know what happened. We get it all the time, right? But pacing is one of those things that you do where, okay, we're going to break it up in cycles. I know that by the time 25 minutes comes by and I'm on that lawnmower, my back is screaming. So as opposed to hitting that 25, I'm going to maybe do 10 or 15. I'm going to take a 10 or 15 minute break, give my body a rest, and go back in for cycle number 2. And when we teach that in pacing, yes, it takes longer, but the recovery is shorter and you're able to get more done than you could if you had to spend a longer time recovering, which puts us in a whole different category of pain and potential injury, right? We also utilize SMART goals with the CBT for chronic pain. When we use the SMART goals, is to help you figure out what does it look like to integrate not only how I'm conceptualizing and thinking about my pain, but what am I doing to work through it? So for example, if you are preparing for the holidays, you got the grandkiddos coming over and they run around a lot. You want to be able to keep up. So maybe it's, I want to increase my physical activity. So what might that look like? So maybe it looks like taking a walk 2 or 3 times a week for 20 minutes because you want to be a little bit more involved with your grandchildren. So we try to incorporate what's important to you. What are the things that are meaningful? And what does it look like to work within your capacity? We want it, that's a big, big, big thing in chronic pain is working within the capacity, not just at it, not over it, but within it in a safe space. The other approaches that we take, such as the acceptance and commitment, or even the emotional awareness and expression, can be a little heavier. In particular, the emotional awareness and expression therapy, which you'll hear a little bit more about, I believe, later in the program. You are really going to work on what are those things that you've been holding on to. So oftentimes, and this is something that we hear from our pain providers, I don't know why they got so upset with me when I tried to explain to them that I think it might be something that's more emotion-based or cognitive-based, right? Because, oh, you're telling me it's all in my head. You're telling me I'm crazy. That's not the message. It comes across wrong. It's not always relayed appropriately, but they're right in the sense that there is no pain without your brain. Your brain has to be involved. That's the way that the body works. That's just what it is. The neural pathways that connect to your pain, guess what? Happen in the brain. So oftentimes when they're saying that, it comes across as, oh, you're just thinking that I'm making this up. That's not what they're trying to convey. And I work with my providers to help them say that in a way that doesn't come off as abrasive and to help them to be a little bit more compassionate. But what they are trying to, or I'm hoping that they're trying to convey, is that there may be some things that are going on within your emotional space and how you're responding that may be exacerbating your experiences in a way where it's impacting how they are able to treat your pain experience, which is why active pain management strategies is so important. And the way that I like to explain this to my veterans is you are the navigator, you're the expert in your life. Your doctor can't touch how you think. They can't touch how you feel. They can't touch how you respond. They can only touch the things that they were taught. So your cardiologist, they're going to work up your heart. If it's your pain physician, they can give you medications. They can look at x-rays all day long, but they can't change how you feel about those things. Only you can do that. And so that's what pain psychologists help you to do, is to recognize those things, put those things on the forefront, organize them in a way that feels safe. So then you can communicate and be on the same page with your providers to get to the pain management that we ultimately want for your higher quality of life. Now, that is easier said than done. It's not something that is done overnight. It is not something that's done in a few months or even a few sessions. But one thing that I always say to each and every one of my veterans, I may not have a magic wand, but I will teach you so much about your pain and how to recognize your pain that you can be ahead of it. So it's almost like it's non-existent. But we can't do that without your participation and you actively doing the work. And so a part of doing that work is as we get to mindfulness and meditation practices for pain management. When we start to think about what it looks like to relax and not reduce stress, remove it. A lot of times, and we say that, oh, reduce your, no. We need to remove it completely. What does it look like to take these things off of your plate and keep them off your plate? And if we are in a situation where we can't necessarily take it off, how can we manage it and navigate enough to where it's not impacting how we are physiologically responding and exciting those nerves? The other things that we have to think about is managing symptoms of other comorbid mental health disorders. So things like PTSD, depression, and anxiety, when you also have a pain experience, and oftentimes is associated with that pain experience, what do you do? This is where I highlight the emotional awareness and expression, because it's not a trauma treatment, but it helps you to understand and realize where you stand. And it's almost, if you think about organizing a closet, you may not want to clean it up, but you can at least separate the pants from the tops, right? You can take that basket and you can put, the shorts and the shirts over here. What does it look like for you to place things and put them away? So when you're ready to pull them out, you're prepared and you know how to manage and how to regulate. And realizing that there's the impact that your relationships and how you navigate in relationships impact your stress and pain management. One of the things that we want to realize is how we respond really can excite, right? Mind and body is connected, which is why Whole Health is such a great program, right? And we'll talk a little bit more about that a little later. So when we utilize these pain-focused interventions, we assist you in navigating those experiences. So what does it look like to prepare for the holidays? That's been my biggest conversation in all of my sessions is, hey, family's coming, Thanksgiving's coming, Christmas is coming. We're gonna have a lot of people that might trigger some things or might say some things that puts us in some spaces. What do we then do at that moment? And how do we navigate? How are we going to be more proactive than reactive? Okay, we have that one cousin that no matter what happens when they come over, your back pain is through the roof. Okay, let's think about it, because we don't want to pull you out, right? And it's a reality. We all have one person that we can think about when they show up, our headache pops up out of nowhere. There's no warning. It's there. You pop Tylenol, no matter what, you're agitated. So what do? That might look like relaxation. That might look like, okay, well, maybe I'll only stay for an hour and leave before that person is there. But learning, what do I need to do for myself, my body, my wellness, my well-being, so then I can set myself up for success. Now, when we start to talk about more of the integrative and holistic methods, now this is where Whole Health can really shine, right? So things like yoga, massage therapy, biofeedback, all these things are supportive options. Now, unfortunately, all VAs don't necessarily have the same type of access to biofeedback, but biofeedback is a thing that we do at the VA. In particular, in the Ann Arbor VA, we do biofeedback. And part of our biofeedback is looking at heart rate variability. So when we think about heart rate variability in layman's terms, we're looking at how is your respirations and your heart rate, how resilient are you? So the example I like to give is the first time you get on a roller coaster, right? You're excited, you're in line, oh, get on a roller coaster. It's gonna be exciting. You get on there, oh my goodness, my stomach fell in my stomach, everything's at the pit of my stomach, it just dropped, I'm doing it again. But then you get back on it and nothing happens. You don't get the same excitement, it's not the same rush. Well, it's because your body knows what to expect. You've been there before. So when you learn what your body feels like at your highs and at your lows, you can return to your baseline faster. And we need that. Because imagine if you have a pain spike and you know like, I'm real far from my baseline, and you learn those breathing techniques to help you get back down to that baseline or even below. Or if you know, hey, I'm going to the mall with my mother and she doesn't know how to not walk around Macy's for hours and hours on end. I need to prepare myself. So maybe you do a couple breathing techniques to pull yourself below baseline. So now as your pain starts to creep up, you can handle it a little bit better. So you're learning about how your body is physiologically responding to stressors in your environment. And in particular, in this situation, it will be your pain. It's also good for a plethora of other things, right? Overall health, wellness, well-being, your heart rate, things of that nature. Sleep, important, right? But we want to make sure that we're paying attention to how our body is responding. What are we putting in and putting out? When we think about the role of diet and nutrition, right, and these lifestyle adjustments, if you know that certain things don't do well and makes you feel a bloat and it makes you feel a little clunky and now everything's out of whack, you want to pay attention to that, because we know when we eat well, we feel well. When we don't eat so good, you may not feel so good. So recognizing those things and living by those things and making them a lifestyle, and it's not a drastic change that you have to make overnight. That's not realistic, right? That may not be in our capacity, but learning those things and adding them in, as you start to add more, you don't use those other things as much. So you start to replace them slowly but surely. And being able to empower yourself to take and challenge yourself to make your self-care a priority. Like sleep, self-care is a priority. We oftentimes will say, oh, well, I was supposed to relax or I was supposed to do this thing. You put it off and you do something else for someone else. Something comes up and then you put it off again and then something else comes up. And so you never really get to it. Before you know it, you look up and you're like, wow, I haven't taken any time for myself. That impacts how you navigate. We're not meant to run like oiled machines, although people make us feel that way sometimes, right? So being able to be an active participant and involving in your pain management journey often looks like you taking control of your self-care, you making it a priority. And it's hard. It's not something that you can do, especially if you're a parent or you're taking care of other people or you have multiple responsibilities. You have to figure out what it looks like to prioritize. And as a pain psychologist or any specialty care psychologist can help you to do. Now, in particular, the VA is moving toward a more interdisciplinary approach for most of their care, but in particular with pain. And that's something that we've been doing for quite some time. The problem is, and this is something that I will admit, it looks different at every VA, even within our own state, right? So just 40 minutes away from each other, right? There's 3 pain psychologists within Ann Arbor VA, but the pain psychologist in Detroit is split between PCMHI and the pain clinic, whereas we have 3 siloed people who can navigate and do things differently and can do other types of pain intervention. So it's not necessarily equal across VAs. And we've been working on what that looks like to standardize the care, but it is still accessible to you. So please ask those questions. Is there a pain psychologist that's within my reach where I can utilize that person? When we think about things like whole health, before we go there, as a pain psychologist, one thing that we do in working with that integrated team is that we are talking to your pain physician. We're talking to your physical therapist. We're talking to your chiropractor. We're talking to your pain pharmacist. We're having those meetings. We're connecting with your psychiatrist. So we are in those positions to be able to say, hey, this isn't working. This hasn't, shown improve. What does it look like for me to shift? What does it look like for us to do something? Something needs to happen. So we can advocate in a way that you don't necessarily have access because we're on the other side and we're with that team. Now, as far as the whole health initiative, when we integrate that mind, body, spirit piece, right, that we talked about a little bit earlier when suicide prevention was here, whole health do provide pain specific type approaches. So if you let them know that you're having a chronic pain experience, you absolutely can benefit from focusing. Sometimes they'll even have them embedded in the pain clinic where we have a whole health person right down the hall. Sometimes we'll walk patients right down and say, hey, can we do that initial introduction, that initial consultation? So don't be afraid to ask to be introduced to these people right within your appointments, especially if you're in a pain clinic. The other thing that I don't think a lot of people realize, Whole Health has a YouTube channel. It's #LiveWholeHealth. And they have a plethora of videos. If you want to hear sounding bowls, if you want to do yoga, if you want to do a meditation, if you want some grounding music, if you need chair yoga, there's plenty of resources at your fingertips, even just on YouTube. Because I know for a lot of veterans that I see, because I tend to have a lot of older veterans, they're like, I don't want to put another app on my phone. I just want to be able to go to it and see it. So that's a good, thank you. So that's a good way to incorporate things into your healing, even if you don't have access to a pain psychologist. And in particular, when we look at the Live Whole Health, they have pain specific meditations for CBT for chronic, or not necessarily CBT for chronic pain, but for chronic pain. In addition to access to care, you do not have to go through the pain clinic to gain access to a pain psychologist. Like I said before, you can access it through your primary care provider. In the Ann Arbor system, it is a health psychology consult. Now, granted, you don't have to use that language. You can just say, I want to see a pain psychologist, and they'll know what to do. They should know what to do. But if they don't, it is health psychology. Now, the value in that is that it's not just pain psychology. We have pain psychology, oncology psychology, palliative psychologists. We have sleep psychology. So we have a lot of things embedded within that consult, and we often will talk to one another and see, okay, well, who's best fit to use this particular care? What does it look like? Okay. The other piece that, as coming to the VA for your pain care, that we hope that you feel is that there's this cultural competency piece, right? So we're truly building this veteran-centered approach. And oftentimes this looks like really taking humility and understanding the military background. What does it look like? Because things don't look the same, right? Civilian care versus veterans care, it looks different. Sometimes we have a hurry up and wait type of thing. Sometimes you get you right in and it's like, wow, that was great. But understanding what it looks like to have those ebb and flows and what it feels like to experience that as a veteran is going to be important for us to understand and lean on you to help us see what that looks like. So being open and letting us know your thoughts on our process, we really do try to listen and incorporate. So for example, as it related to our warm handoffs in the pain clinic, we often heard the feedback that a lot of the veterans felt like it took too long, right? So that's where we started to do more access and we changed the way that we did the process to better accommodate our veterans. So that might be a phone call to do your suicide screen on your way in. So then when you come in, your process looks a little bit different, okay? We also want to make sure that we're always fostering that trust and rapport throughout as we hear your experiences and we walk through your experiences. And oftentimes in that VA setting, that's what you're going to get, right? We know that there is a mindset that comes along with being a veteran. The military culture is a beautiful culture and want to be respectful to that. And in particular, in pain management, we try to even use a little bit of your military culture to help you to navigate, right? So acknowledging and adapting that into your unique pain management plan can be really helpful, right? So sometimes I have veterans come in and says, oh, well, I just got to embrace the suck. Okay, that's fine. When you're active duty, you're civilian now. We don't have to embrace it the same type of way. What does it look like to embrace it here, right? So understanding how to navigate and just really being open and honest about what those experiences look like. So some of the key takeaways that I would like for you to take from my presentation today is that multidisciplinary approach, that multidimensional approach is so important to us as we approach your care as a veteran. In addition to understanding that there are resources available for you both in and outside of the VA setting, but we want you to be able to know what it looks like to advocate. So asking the questions, asking for the specialists. I know community care is a hard thing, but sometimes we don't have to go through community care. Sometimes it's a matter of relationship, right? Ann Arbor's across the street from U of M. So we have questions, sometimes we'll just call, right? And we can get access to things and help you to make connections. And also understanding that we recognize that need for that cultural understanding and providing that effective care. Your care just looks different. And that doesn't mean that it's wrong. That doesn't mean that it's problematic. That doesn't mean that it's tough. It just is. And from the people that I know and myself, we wouldn't have it any other way. Love working with veterans. That's why we do the work that we do. And ultimately, we are here to help you navigate your journey, whether it's pain or otherwise. Okay? What questions do you have?
So, I rated people on to find, help in had multiple comorbidities, things going on by the time I finally found help with, Dr. Pendleton at the Canton VA, center there and that kind of stuff. So what I'm wondering is, are there any indicators and things that I should look for? Because I didn't go when I should have, or reached out when I should have. Are there different things that I can, that you might see as indicators that might be, yeah, hey, it's time to reach back out. You know, that if you're experiencing this, and this, that's when you should. Don't wait till you sit in the chair for 2 weeks and your wife asks if you're going to get up today.
Gotcha. So the question was, what are some signs to reach out before, you have to start being more aggressive in your treatment and really reach out like to the dire end? And so one thing that I always say is a key indicator is changes to your norm. So if you're noticing some changes to your norm, if people are saying like, are you okay? But there's nothing physically wrong with you, that might be an indicator. If you recognize like, wow, I'm feeling a little bit off. You may not be able to put a name to it. Check in. Even if you're not sure, it could just be that you have a bellyache that day. I always say check in. I'd rather you check in and we tell you that it's nothing than you not and it's something, and we need to be a little bit more proactive in how we navigate. The other thing is you don't have to wait at all. You can just be in care. You can see a pain psychologist and there be nothing inherently wrong outside of you just wanting to work through your pain. So don't be afraid to reach out to providers who specialize in this work well before something comes up, because that ultimately is your preventative care, right? Because you know what it looks like because you're already there, you're already talking about it. And now, as opposed to scrambling when it happens, it's right there front and center and you're just pulling it out the tool bag. I have a question over here too.
because the military culture is not to say ouch.
Yeah.
And I've learned not to shoot it on my film or shoot that people shoot on me.
Yeah.
So it's a paradigm shift
Mhm.
to go from the military culture where you don't say ouch to have the space to be able to say ouch. And give yourself permission to say ouch. So I think.
Thank you.
We have a question from Zoom.
Mhm.
How do you figure out what pain management technique you need?
The question was, how do you figure out the pain management technique that you need? Really talking to us. Just let us help you. Because sometimes it may not be medication. It might be a matter of just your habits, right? So if you have bad ergonomics and you work from home and you're sitting in the wrong chair and you're like, my back is falling apart. Oh my gosh, I'm going to need spinal surgery, when really you just need to replace the chair. So being able to talk to us about the symptoms and let the pain team do the magic, right? But understanding that you're still driving the car, because we don't know how to fix what we don't see, what we don't hear, what we don't experience from you. So let us be that soundboard for you. If there's something that hurts and you're not sure if you're injuring yourself or not, ask. We can always look. There's no problem in us looking and figuring it out and helping navigate that process. All right. Do I need to end it? Thank you.
Okay, so we've been notified that lunch is running a little behind. So we are gonna move on to our next speaker and hopefully it will be arrived by then. It's okay. There's still some snacks if anyone is, fainting. And so our our next speaker is going to be Amy Bohnert. She is going to present on opioid research. Amy is a mental health service researcher with training in public health who focuses her research on epidemiology and brief interventions regarding substance use and related disorders. Please welcome Dr. Bohnert.
Thank you. Thank you very much. Am I okay on sound? Is this picking me up? Okay, perfect. So I have to admit, it's a little bit of pressure to give the talk like when people are waiting for lunch because lunch is delayed. So please bear with me. And again, if anybody wants to get up and get a snack, please do it. So I thought I would start. I am a professor in anesthesiology in the University of Michigan. I actually also am a employee of the Ann Arbor VA. I have some of my time doing research at the VA Center for Clinical Management Research. And some other disclosures, I have funding from the VA, NIH, a number of other places. I've done some expert witness work related to opioid settlement funding for the, I was an expert witness for the Michigan Attorney General in their cases against some of the opioid distributors, no other financial relationships. I thought I would start by talking about why I started studying opioid overdoses and the public health crisis around opiates. I was a PhD student in public health in 2008. I was living in Baltimore, and I was at the time studying how drug use moved through social networks, which in Baltimore, that was often heroin and cocaine. And at that time, I had a friend who was in recovery from heroin addiction. She was in her 20s. And had not used any opiates in several years. And then it was her birthday and she was at a party and was offered heroin and she used, and I think not understanding tolerance, used what had been her normal amount before, but caused her to overdose. And what struck me when, and she died. And what struck me is that there are tools that were known at the time to be things that could have saved her life and that she did not have access to and she did not use. So I'll talk more about these tools, but in particular medications for opioid use disorder. She had been in abstinence only treatment because a lot of the stigma around medications, and she would have been much less likely to overdose had she been on those medications because of how they work.
She also did not have access to naloxone. People at the party could have saved her life if they were carrying naloxone, but nobody was, and they were scared to call the police. And so by the time they did, it was too late. So that is my story of why I do what I do. I'm going to talk a little bit about the opiate crisis and how we got where we are now. When I started moving to this topic in that 2008 period after this had happened, that was kind of the beginning of there starting to be noticed what was going on with opioids, and I'll show some data on that. I just mentioned two particular tools that are really critical, important medical and public health tools, but I'll talk about some others as well that have come through research, a lot of it actually starting with veterans, but research that is of what evidence can be used. I'll talk a little bit about where I see as really key gaps. As those tools have gotten used in the community, we have some evidence from research about who maybe isn't being reached and where there could be improvements, and then just summarize that a bit. So how did we get here? So this is data on the common causes of death in the United States. And this is graphed as a change in level, right? So oftentimes you just see kind of lines changing over time. It's a little bit hard to interpret. I thought this is a helpful way to conceptualize it, where you look, if you took 2006 as the start, how for each cause of death has it changed over time? And what's really clear is unintentional overdoses have dramatically increased. Suicide deaths have increased as well in this way. And I think that's important to note. I know one of the talks today, I'm not sure if it already happened or is happening later, we'll talk about how the suicide crisis is a piece of this as well. But I think that's important. And what you see at the same time is a lot of the other common causes of death that are caused through health behavior like diabetes, heart disease, infectious diseases, cancer, all of those have actually improved a little bit over time. The rates have been declining. So I think that really shows this fact that as a lot of the benefits of improved healthcare have accrued in things like reduced cancer rates, despite that, we see these dramatic increases in overdose deaths. I also want to be sure to note, I talk a lot about overdose deaths. They're obviously the most severe problem that we want to address as part of this crisis. They're also often, frankly, very measurable. So it's easier to track what's happening over time there because of the way that deaths are counted and because of surveillance in the United States. But that's really just the tip of the iceberg here. For every one death, there are 15 people who have a substance use disorder involving heroin. There's 41 people with a prescription opioid related use disorder, and another 273 that report some type of misuse of their opiate. So without having a full use disorder, have some ways in which they're using it that are not safe and could potentially lead to an overdose, because not everybody who has an overdose has a substance use disorder. This has become maybe somewhat controversial, and I'm happy to talk about it a bit during questions, but how this got started, how the deaths in opiate overdose really started to ramp up, had a lot to do with how opiates were being prescribed in the US. So there was the effort to make pain as the fifth vital sign, as others may have mentioned, which meant that you're being asked it. I mean, we've probably all experienced this, right? You go to the doctor now and you're asked, what is your pain level? And you may be asked it repeatedly every time you change hands in that clinic visit, or if you have a procedure done, you might be asked 20 times. That was a new initiative that did not exist before. And often when you're being asked to assess something, prescribing something seemed like the easy solution to fixing that problem, as opposed to the multimodal pain care activities that the VA is doing now. When this first started being assessed regularly, often prescribing seemed like the easiest way. So you can see from this graph that the opioid sales, which is the green line there, really tracked closely in the early 2000s with both opioid-related deaths and the increase in people having addiction. I think an interesting piece of early evidence that the prescribing and overdose deaths were related was this analysis that was done that compared states that were tracking their opiate prescriptions. So before every state tracked everything, there was an earlier system which was what was called doing a prescription in triplicate. So when a doctor would write a prescription, there would be multiple copies and they'd have to send a copy into the state. So this kind of predated the electronic systems that exist now, but some states were doing it, some were not. And I think is a signal that a state was tracking prescriptions, trying to make sure that there wasn't particular doctors who were over prescribing a ton and monitoring it. Those states that did the tracking had slower increases in opiate overdose deaths than the states that did not do the tracking, which is the red line there. So I think some early evidence, or there was some early evidence that the kind of ways in which opiate prescribing was happened in a kind of unrestrained, unmonitored way was particularly bad for public health. All of that said, as a lot of people have probably heard, this problem has really changed. So the early problem was about a lot of more opiate prescribing and a lack of safety around that prescribing. But there's been really 3 waves of what's considered the opiate overdose crisis. The first was that drive and increase in opiate prescription opiates. So that's the first area here, and that purplish line is the overdose death rate or overdose deaths that were due to prescription opiates, not necessarily to, the death was the person who was prescribed it, but that class of drug. Then there was the rise in heroin overdose deaths, which started around 2010. And really heroin being the driver lasted only a couple years. And then what has really taken off is the synthetic opiates. So this is the illicitly manufactured fentanyl that really now is the major driver of opiate overdose deaths in the United States. If there are questions about it, I think these are, there's some shared drivers for why all 3 of these has happened and why they've gone up, but I think there's also some distinct factors. I think the lethality of street fentanyl is a huge part of the problem. So there aren't necessarily more people with an opioid use disorder or more people using opiates illegally than there were before. But for a person who uses it, their chances of dying are much, much higher because of how potent the drugs on the street are and how much more potent they were than heroin 20 years ago. So that's my kind of overview of the epidemiology and the status of the crisis. I'm going to move on and talk some about what are important tools that can be used to address it. Hopefully what came across is that it's definitely not one tool is going to do it. There's a couple different problems happening with different drivers at the same time here. So really from a health system perspective, when you're talking about the VA, or from a community and societal perspective, we need to be using all of these tools. So that involves knowing the different patient populations that are affected by this. So there's first opiate naive people with pain, and this is really about prevention, how to prevent people from being unnecessarily exposed to lots of opiates or have their family members exposed because of a lot of unnecessary amount of opiates are going into the house. There's those on long-term therapy with chronic pain, and then there are people with opioid use disorder. So these are actually fairly distinct groups, need a different combination of tools to address the problem. I mentioned the people who are opiate naive first. I have some colleagues at the University of Michigan that have done work on opiate prescribing recommendations. So when they started this project around 2017 or so, Michigan in particular was kind of a leader in volume of opiate prescribed, and they worked with the quality collaboratives that work with hospitals that do surgery around the state, collected data on how much opiates people actually used after their surgery, and then created recommendations to better fit by the type of procedure you have, the amount prescribed to the amount people actually needed. So this is an example of those recommendations, but what's really encouraging to see, so after they released the guideline in the state of Michigan, the amount of opiates prescribed went down pretty steadily, as you'll see there. But to me, the really interesting and exciting part of that is that as the opiate prescribing went down, the opiate consumption reported by patients continued to go down as well. So it's kind of the supersize me French fries effect, where if you order the biggest size, you'll eat the biggest size. If you order the medium size, you'll have the medium size, and like everybody leaves a little bit behind. So the amount consumed continued to go lower and lower. But the even more exciting part to me is that even as the amount of opioids were reduced, patients' pain scores that they reported around that procedure and their satisfaction with their care was completely stable. So the blue line and the red line there in this graph, no change even as people got fewer opiates after their procedure. So this is, to be very clear, the stance here is not from the group and from myself is not that opiates should not be prescribed after procedures, but that the amount that is prescribed should be a sane amount for that procedure that happened. I'm glad I got to catch the talk before on multimodal pain care. I think this is a really important part of providing good and humane care to people in that chronic pain group in the middle, that opioids are an important tool there, but they should not be the only tool, that people should have access to lots of different options. The VA has done that really well, and frankly is a national leader in that area. I mentioned naloxone. So naloxone is a medication that can reverse an opiate overdose. So when someone has taken a lot of opiates and they're losing consciousness, that means that the opiate receptors in their body have a lot of opiates on them. And the naloxone is an antidote that knocks the opiate molecule off the receptor and can very quickly and very rapidly reverse the opiate overdose. It used to be largely available as a injection. So it was mostly distributed to people who, it's what emergency medicine technicians use, but it was mostly distributed to people who used injection drugs so that they could use it with other people who were using injection drugs. They were very comfortable with injecting. Fortunately, formulations that are a nasal spray were developed. So this is much easier to use in a general population. You can often you can get this in a number of different ways. There's a lot of programs in the state. This is something Michigan has invested a lot in. So if anybody has questions about how to get it for any organizations they're involved with, please follow up. We can help with that. The key things, so the great thing about this nasal spray version is it's about $40 a unit, which is really quite cheap for a public health intervention. There have been continual attempts by pharmaceutical companies to push out versions that are much more expensive and that kind of make, let's say, inflated claims about how much better they'll be. So, for example, there was an auto injector version that was $800. That fortunately, hasn't really gotten part of the market share for good reason. I think more recently there's a new version that is a higher dose amount, with the premise that because the fentanyl overdoses, there's so much drug on board that maybe people will need a higher dose of naloxone to reverse it. However, what the data shows is that the overdoses are no more likely to be reversed, like in the actual community use with those medications. So do not buy the more expensive version. The $40 version is perfectly fine. There was a cool paper done. One of the better evidence for how these programs could work was a paper done by a colleague who is out in San Francisco, who studied what happened when clinics co-prescribed naloxone with a long-acting opiate for patients with chronic pain, and found that opiate-related emergency department visits went down considerably after they started that program. Another thing just on the topic of kind of what to public health interventions is disposal. So if you have a procedure, you have leftover opiates, it's very typical for people to just leave them in the medicine cabinet, which is particularly, I think, risky with when there are kids in the home. So there are increasing disposal options around the state. Pharmacies are increasingly having disposal boxes like this. There are also medication take-back drives, and I think that's an important part of it. Another intervention, and this is really for people who are with a substance use disorder who are using drugs, but are fentanyl test strips. Historically, these have been used by people, or were distributed to people who thought they were using heroin to check whether or not their drug was heroin, so that if it was fentanyl, they could not use it, or they could go much slower than they would have normally used. This was more, I would say, more relevant in the part of the pandemic of the opiate epidemic when fentanyl contamination was the big issue. In most places today, and I think Detroit is certainly one of them, people know they're not buying heroin. You can't buy heroin. What you're getting is fentanyl. Most people know that. So testing it doesn't have that much of a point. But where it is really helpful actually is for people who are stimulant users. So cocaine, methamphetamine, other drugs like that. They are often now contaminated with fentanyl as well. So testing drugs can be really important to that group. I mentioned medications for opioid use disorders. The main ones listed up there are methadone, buprenorphine, and naltrexone. I could do a whole long talk on just medications for opioid use disorders, so I'll just say broadly, lots of evidence that people have better outcomes of treatment if they are getting one of these medications for an opioid use disorder. Most substantially, a pretty dramatic decrease in mortality and overdose deaths relative to abstinence-only treatment. We've also done some work looking at counseling approaches for reducing opiate misuse. You may have noticed of the different types of problems I've talked about, there's the least data for what to do for people who have low-level opioid misuse without a full-on opioid use disorder. So we did a study a couple years back where we looked at a brief 30-minute counseling intervention compared to just standard pamphlets on opioid misuse. We did it with people in the emergency department and found that 6 months later, the people who got the intervention had lower levels of both overdose risk behaviors and opioid misuse. So I think that's one option for treatment. There's been some evidence for how to treat opioid use disorder in primary care and lots of different approaches. And I'll just say the high-level summary of all of these seem to work. So it's important for it to be in primary care. How exactly it's implemented, there's a lot of leeway to do it in the way that makes sense for a given clinic. There's also some good evidence for the increase in, for use of the medications for opioid use disorders, not just in reducing an individual's level of overdose risk, but it having an important impact at an entire community level. So this is data from Baltimore after they implemented a program to make it easier for physicians to prescribe buprenorphine, and before prescribed opioid overdoses started to increase, they did see actually meaningful reductions in heroin-related deaths in the city. Just a couple quick thoughts on who's being left behind. And this might be, again, something I'm happy to talk more about. I'll try and cover real quickly. I'm increasingly concerned that patients who are prescribed long-term opiates for chronic pain, if they have some reason why they need to change their treatment, whether it's their prescriber is concerned and says, I don't think we should keep doing this, whether it's that their prescriber retires, they have a hard time finding new treatment and can end up withdrawing precipitously and in an unplanned, uncontrolled way, and that is clearly bad for patient outcomes. So this data came from a secret shopper study led by my colleague Pooja Lagasetti. So the team called clinics and went through a script as if they were scheduling a appointment for their mother, and mentioned that the mother was on long-term opiates and asked whether that would be a problem. And about 40% of the time, the clinic said, no, we're not going to be able to take over the prescribing of opiates for that patient. So, and this was all in Michigan. We did a little bit of a look at whether the type of reason why they were prescribed, why they said they needed a new prescriber mattered. So we compared whether if you said that the mom's prescriber had retired versus saying they've just said they're going to stop prescribing it, if that makes a difference. And we did find that the new clinic that they were calling was more likely to say that they would not take over the prescribing if the person said, I don't know why, but the doctor just said we're going to stop prescribing, rather than saying that the patient retired. So I think, unfortunately, probably the patients who are in the highest need in terms of, maybe it is that they've developed an opioid use disorder, but they need to be transitioned to medications, not cut off. and who are going to be at the most risk for overdose. Those are probably the most vulnerable patients and are also the most likely to end up in this situation of being an opioid refugee, where they have a fractured patient-provider relationship and precipitated withdrawal. Just one other thing, I've mentioned a couple times, buprenorphine is a particularly great treatment for opioid use disorders. We did a paper a number of years ago and found that this is with national data, so not veteran specific, but that the increases in access to buprenorphine were unfortunately really just for people who were white and for people who were on private insurance or self-pay. So access had not improved for non-white individuals in the US or for people on Medicaid or Medicare. This gap has started to close a little bit, but unfortunately I think is concerning and something that needs to continue to be a way in which systems are evaluated for whether they're providing the right services. So I'll just kind of go through these real quick. These are what I see as the key tools that should be offered. If you are looking to, think about whether a program or your county leadership or state is doing what they should be doing, these are the things I would highlight. And that is what I have. Happy to take questions for a couple minutes. So thanks.
So in terms of Narcan or naloxone, how in the community health or public health initiative to help increase access to that? Because $40 is not a big, it's not a big cost, but it can be a barrier for some folks. For example, Wayne State has for their students a vending machine where you can just put your ID in there and they'll give you a dose of it. And I think that a couple of our health systems, the local health systems, have also partnered with like the mobile health unit to go out to the spaces where people are maybe consuming these opioids to hand those out. But generally, it seems that we have a hard time finding programs that exist like that. Does something like that exist specifically for veterans that you know?
That's a good question. Sure. Yes. So the question was, there's definitely some exciting work that you've heard of, and I'll comment on that a little bit too, of novel approaches to getting naloxone out into communities where it can be helpful. Is there anything like that for veterans? So I totally agree with you that there's some exciting work on like the vending machines in particular. My own naloxone that I carry, I got from the vending machine at the Ann Arbor District Library. And our hospital system has one now near the emergency department as well. Meaning the U of M hospital system. And I also agree with the point you're making that like the more proximal those can be located to places where people who use illegal drugs, the better, right? Because that's the group that's at the most highest risk for overdose. To my knowledge, I'm hopefully wrong on this, but to my knowledge, the VA hasn't implemented that vending machine type model yet, but they have done a lot to try and increase naloxone co-prescribing and just naloxone prescribing generally. So they do a lot of performance evaluation, and health systems are held accountable to making sure that they're making naloxone available. I know there's been programs to actually just send naloxone kits to patients who are on higher opiate doses to their home. I think it was a well-intentioned effort. There's maybe been some pushback that it sends a message of you're at risk, but it's not delivered by a clinician directly who could talk about what that risk is and help the person think it through. And that was, I think on the whole, it was good to be sending it to people, but lacked a little bit of nuance. So yeah, thank you.
We have a question from Zoom. What can someone do that is dependent on opioids to gain relief from their chronic back pain?
Great question. So there's some data that sorry, I'll repeat the question. So the question was for people who have an opioid use disorder, how can they get relief for their back pain? And I think the underlying part of that question is, presumably using prescribed opioids could carry particular risk for that person for worsening their opioid use disorder. There's some emerging evidence that the buprenorphine, one of the medications for opioid use disorder that I mentioned a couple times, that is what's called a partial opiate agonist. So it works a lot like a opiate agonist that people use for chronic pain treatment. It works a lot like OxyContin, for example. But it has some safety features and is less likely to cause, or can't really cause euphoria the way OxyContin can. So there's some emerging evidence that that particular treatment of the treatments for opioid use disorder has some pain benefit as well. So I think my first recommendation would be to look at getting into buprenorphine if someone's not already on it, in terms of taking a medication that has the potential to help their pain as well. And then after that, I would say really looking at all the multimodal pain care options as complements to that medication, or potentially in some cases, maybe as primary modes of treatment, that would be a good option. Yeah.
The differences of the communities that can have access, is it associated with racial disparities in healthcare, or would it be funding?
From this one? Yeah, it's a good question. This was data collected from primary care clinics. So it wasn't differential access in the sense of like people who weren't even getting any primary care weren't included here, right? It's possible that these are just looking at one variable at a time, and insurance type is probably related. There are probably differences by community in insurance type. So to the degree that one is the causal driver versus the other is probably beyond looking at the data this way, but that is one potential explanation. There's been a lot of work in the opioid prescribing space for chronic pain that physicians typically take complaints about pain less seriously from their patients when they're Black as opposed to white. I don't know if there's some carryover of that here too, that they may be less likely to recommend buprenorphine over other treatments for opioid use disorder, take it less seriously, or take the pain component that may be a part of that less seriously. The colleague I've mentioned a couple times, and who was the first author of this paper, Pooja Lagasetti, did a online study nationally recently looking at patient preference for treatment. And there are some racial differences in patient preference for treatment where non-white communities, if they were asked to say, what would you want like a family member to do if they had an opioid use disorder, were more likely to endorse abstinence-based treatments. However, after a 10-minute educational video on each of the treatment options, those differences completely went away. So there may be some differences in community beliefs about treatment, but that also are clearly amenable to communication. So, okay, I'm getting the message that time's up. So.
I heard something. Hi, everybody. So still no food, TBD, but we're going to continue. And then when the food is here, we will consume it. Our next speaker, we're going to hear about Cannabis for Pain by Dr. Kevin Boehnke. Kevin is an assistant professor in the Department of Anesthesiology and the Chronic Pain and Fatigue Research Center. His current research focuses on therapeutic applications of cannabis and psychedelics. And please welcome Dr. Boehnke.
All right, thanks y'all. And, I guess it's topical to talk about cannabis now, including because we all have the munchies waiting for this food. So just hang in there. I'm sure it will show up. But yeah, thank you all for coming, for your kind attention. I just want to start. Oh, whoa. I need to be able to move to my next slide. There we go. Just want to start out with some acknowledgements before I get into the scientific content. So just a wonderful group of colleagues, trainees, patient advocacy partners, and then the members of our community advisory board, some of whom are here with us today. And then also just noting that I do have some disclosures. I'm funded through multiple NIH grants, as well as through the state of Michigan. One of the projects that that Brian mentioned, funded through the CRA, is done by our group through VMR 2022-03. And then also received some protocol development funding for a psychedelic assisted therapy study from Trip Therapeutics. So with that, we've already covered some of this, so I'll be able to move through it a little more quickly. But, you know, hemp, cannabis, marijuana, all of these refer to the same plant. It just really depends on how much THC is in the plant. So hemp classified as having less than 0.3% THC. This is the compound that gets you high. Marijuana typically refers to cannabis that has more than 0.3% THC. And cannabis is the more scientifically accurate term. I'll just use that for the remainder of the talk, especially given that it wasn't used in cannabis prohibition campaigns. So the two most popular cannabinoids, you know, these are unique chemical compounds found in the cannabis plant, are THC and CBD. THC is analgesic, it's mood altering, it's appetite stimulating, and it's actually been FDA approved since the 1980s. For HIV and AIDS related wasting, as well as chemotherapy induced nausea and vomiting. So in contrast, there's CBD. This does not get you high like THC, and in fact, has no abuse or addiction potential, such that when there was an FDA approval of a CBD-based medication called Epidiolex in 2018, it was initially Schedule 5 and then removed from the Controlled Substances Act. So it's no longer a controlled substance. So this is, you know, in part what Brian was talking about with the industrial hemp bill, but this is just actually the only approved medicinal form. It's called Epidiolex. This compound has a lot of exciting properties. It's non-intoxicating. It may be anxiolytic, so help with anxiety. It may be anti-inflammatory based on non-human studies. And it's clearly a potent anticonvulsant, since that's what it is FDA approved for, is orphan seizure disorders. And then there's many, many other cannabinoids. I'm not going to go into them in too much detail, but just know that they exist. There's over 100 of them, and people are studying them because, as with many of the other compounds in this plant, they're thought to have therapeutic potential. And again, Brian already talked about this. We have this huge mismatch between federal and state policy. So we have 38 states with legal medical cannabis, 25 with legal adult use now after the last election. And this is in spite of cannabis being Schedule 1, which defines it as having no accepted medical use and a high potential for misuse and abuse. This rescheduling is potentially on the table. DEA is reviewing this now, but as Brian said, we don't know what the outcome will be. And if it's just a rescheduling, it probably won't change too much in terms of this mismatch in policy. But within this context, what we do know is that use, especially for medical purposes, is growing. So in states like Michigan, where, you know, adult use laws pass, there's a steady decline in patients who are in these registries, but still from 2016 to 2022, the number of people using cannabis medically increased by over 600%, from about 680,000 to over 4.1 million people, most commonly for chronic pain. So more than all other conditions put together, if you look at this top gray line, that's the number of people with using cannabis for chronic pain. All these other things put together, arthritis, multiple sclerosis, PTSD, nausea and vomiting, cancer, all less than use for chronic pain. So there's a very strong need to understand how to appropriately use cannabis in a thoughtful way to minimize harm and maximize its benefit in the context of chronic pain. Unfortunately, the clinical trials don't tell us too much because, one, they don't use any of the products that are available in dispensaries. The ones that they do use are, you know, those pharmaceutical grade products that I mentioned. I'll go a little bit into this more in a following slide, but you'll see the difference in the sorts of quality of these. But also, everybody has, all the scientists who have looked at the quality of these trials have said, gosh, they kind of suck. They're short length, small sample size. They don't use products that are generalizable. And despite this, there's some support that these might help with neuropathic pain. There's some risks of short-term adverse events like dizziness, dry mouth, sleepiness, which in some cases sleepiness in the context of pain is a positive side effect if you're having trouble sleeping. But you know, definitely some concerns that we should be aware of. But as I mentioned, the drugs used in these clinical trials is just simply not the same. So again, pharmaceutical grade cannabinoids, and then this sort of brown powder that was how it was processed and sent out, that was grown at the one federally licensed grow site at the University of Mississippi. So it was the only federally licensed grow site for decades. And of course, this looks much different than what we can probably go down the street and buy. Very high quality cannabis flower, cosmetics, beverages, candies, capsules, any number of things, topical products. And so this affects how people might experience these products and what they might do to their pain. For example, compared to a clinical trial where, say, you might take 5 milligrams of THC twice a day, that's your schedule, that's what you do. This is what people, some examples of what people actually do. So, you know, I take this top one, 2 drops of 1,000 milligram CBD oil twice a day. That's more like what you'd see in a clinical trial, but look at this description here. I medicate with 5 milligrams of a 2-to-1 CBD THC gummy, then I vape, then I microdose, and I get home and I have 2 milligrams again, then I vape a small amount. Then before bed, I water vape, and then I take a 5 milligram dose of a gummy. You're not going to test that in a clinical trial with these pharmaceutical formulations. Nobody should be expected to. And so what we need to do is try to understand how we might implement that sort of design in a clinical trial setting so we then can understand if that produces different results. So how does using cannabis products for chronic pain affect use of other pain medications? We found, and this has been replicated in many other studies by many other groups in many other states and countries, that some people substitute cannabis products for other medications. So this was in a group of over 1,300 people using cannabis for pain. And if you look, so of those, 691 substituted cannabis for opioids. Of those, about 70% said they stopped using opioids. Another about 20% or so said they decreased their use a lot or decreased it a little. And a small percentage said they increased their use. This occurred with other medications as well, including benzodiazepines, gabapentinoids, NSAIDs. And so this is exciting. This clearly doesn't apply to everybody who is using cannabis, but at least in a subset of people, they do find it a helpful enough medication to use it in place of these other substances that do actually have overdose death risk. As we heard from Amy, with cannabis, the likelihood of a lethal overdose event is incredibly low. It is almost unheard of. We know that this happens with CBD as well. This is the non-intoxicating component of cannabis, or one of them. This was in a group of people with fibromyalgia, and we see a similar trend in this substitution of CBD for other medications. And again, as I said, these studies that we did in our group, if these were the only ones, I would be more skeptical of them. This is a sampling of the dozens, if not hundreds of studies that have now been published replicating the same trend. So again, it's not everybody who does it, but at least a subset are able to do this substitution successfully. And then there's also the question of how integrated is cannabis into medicine. I think one of our audience members asked this earlier on about psychedelics. And unfortunately, I would call it a communication breakdown. So how do people select their cannabis products? Typically with a bud tender rather than going to a physician to get any kind of advice about what to use and how to use it. Where do they purchase them? Online or at dispensaries? We already heard from Brian about what happens if you purchase products online. You don't have that kind of quality control to know what's in your product, to know that it's actually tested. How do they select their CBD products? Mostly through personal research, mostly through the advice of an employee at a place of purchase, much fewer due to the endorsement of a medical professional. So all of this I say in part because it informs likely what will be coming in this changing psychedelic landscape, as well as what is already happening in this currently legal medical cannabis landscape. We also know that physicians lack confidence and comfort in their knowledge about cannabis and how to integrate it into treatment. So we surveyed over 200 physicians, and only 8% rated themselves as moderately to extremely knowledgeable about how to integrate cannabis into treatment. Similar amount, about 18%, somewhat are very comfortable about incorporating cannabis into treatment, while over 60% said not really comfortable, not really knowledgeable about this. And we also asked them a standard set of questions from the scientific literature asking, what are some known effects of these compounds, all these sorts of things. And about 58% of these questions were answered accurately. So clearly a lot of gaps in medical education around what the effects of cannabis are, and then ideas about how to incorporate it into medicine. So we know people are using cannabis for chronic pain. It's the most common reason. We know they substitute cannabis for pain medications. We know they use a wide variety of cannabis products that in no way translate to what's been happening in clinical trials. And we know that it's poorly integrated into mainstream medicine. But I think that we have enough information to know that we can do this in a better and more effective way. And so I'm so honored and delighted that we were funded by the state of Michigan to do our Michigan Veterans Cannabis Research Program, which we've called MyVetsCan, and for which we have many of our wonderful colleagues and staff and everyone here today. And we're doing 2 large clinical trials within this. The first is we want to understand if CBD helps with the pain experience. So as I mentioned, there are those non-human animal studies that have said, oh, this might be helpful with anxiety, with inflammation. We want to understand if that will help veterans who have pain. And then the second intervention that we're doing is more of a coaching intervention, where we actually help people optimize their use of products that they can buy themselves at cannabis dispensaries. And then as we help them refine that use, see if that is useful for their pain relief. So as I mentioned in my acknowledgement slide, we have a community advisory board. We'll hear from some folks on that later. And something that we've loved about this project is we've been able to engage with veterans from the get-go. When we came up with the idea for this project, we brought in veteran voices to say, what do you think of this? Like, is this something that you would actually want to do? And so, and then when it got funded, we officially formed this board that consists of veterans living with chronic pain, veteran and community-based organizations, healthcare providers, and pain researchers to inform research at every stage of the way from, as I mentioned, the study design phase to the figuring out how we can modify our language to be most effective and communicative, to, informing people that this research is going on, and then to disseminating the results both back to veterans, to the VA, and then in partnership with the Cannabis Regulatory Agency across the state, for example, in dispensaries. And so all of our studies are currently recruiting, which is very exciting. And so actually this figure was helped designed by our community advisory board. And so you can see that there's multiple options to get into the study. So you can do the CBD study on its own, you can do the coaching intervention on its own, or you can do CBD and then coaching. To get into any of these studies, you also have to join a study registry that connects you with the study app. The study team teaches you how to work with that system to monitor your own symptoms and cannabis use. We've published the protocol just to make this very open access and available and transparent of this is what we're doing. And this is what things look like for the CBD study. People screen, they come in, we ship them CBD to their homes. And so then they can flexibly dose the amount that they take within boundaries that we've come up with. And then when they're done with the 28 days of taking CBD, we have a prepaid envelope that they can send it back to us so we can just make sure we know how much they have used. And we, of course, provide support on, how to use it, how to use the data capture system, all those sorts of things along the way. For our Can Coach intervention that we're doing, we're really, again, focusing on harm reduction and benefit maximization. So we think about things like, how do people take it, routes of administration? Do they take CBD or THC? How much do they take? And when do they take it? Because those things so clearly affect the outcomes of that use. And so we actually completed a feasibility study of over 20 individuals, just to see, one, if people liked it and if they found it to be preliminarily helpful. This manuscript is currently under review, and we actually found that, yes, people were very satisfied with the intervention. They thought that it was quite helpful. So most thought it was very helpful or extremely helpful. And then we used this one item scale called the Patient Global Impression of Change, basically asking, like, globally, how are you doing since this intervention? And over 60% said much to very much improved. What this is considered to be a clinically relevant and meaningful outcome. And even in the pain space, minimally improved is thought is now considered to be clinically relevant as well. So basically saying that everybody who went through these studies did well. They didn't have serious safety effects. They had positive improvements in their symptoms. And so in summary, we know that the data on the health effects of medical cannabis are limited in chronic pain contexts. We need to understand, of these people who report benefit, why, who they are, what sort of things we can do to maximize that benefit. And that there's also many ways that we can think about study designs that actually can understand the risks and benefits of cannabis in the chronic pain context. So yes, we can go through the FDA, and we're doing that for our CBD study. And that's a great way to understand the effects of CBD. But through this coaching intervention, we can also understand, what do all these products that are available, how do we teach people to weave them together in a skillful way that actually meets them where they're at and teaches them and empowers them to make those decisions in the future, which honestly, I believe applies to all medicine. Like, if you just take pills in a specific way, like, that might not fit with your specific symptoms. And you need to have people need to have the confidence and the ability to advocate for themselves to say, this is not working for me, and go back to their physician or their healthcare provider to say, we need to do something different. And I believe teaching people that about cannabis can bleed into other places in their healthcare as well. And then lastly, I love quoting this paper by David Nutt and his team, this idea that every time a medicine is prescribed, an N=1 experiment is being conducted. In some patients, the experiment works, and in some it fails. We know this with every single medication. There is no silver bullet, especially when it comes to pain. So cannabis is no different. Let's demystify it and just allow people to add it as a tool in the toolkit. In some it will work, in some it won't, but let's maximize the chance that it might be helpful and minimize the chance that it might be harmful. So with that, thank you all for your kind attention, and I welcome any questions. Yeah.
So the cannabis you use is that medical grade stuff in the South for your research, correct?
So
And how fitting this out with what we actually are getting out there, which I'm finding is definitely not as good as the medical grade stuff. And do you see any hope for the future that us in society is going to have access to that good medical grade stuff?
So the question was about the differences between the medical grade stuff in the research versus what people can access generally, and is there going to be a confluence of those in the future? So actually the stuff that's tested in clinical trials, that's like the brown powder in the hand of that dude in the photo. That's not very high quality cannabis. There's concerns about that having pesticides, mold, heavy metals. This has shown up in several studies. It's very difficult to access that supply chain because of some of these issues historically. So I personally think that, like, if they're doing a better job now, but like that's stuff that is different than what's available on the state market. I think that's not to say the state market is perfect, but if we have solid regulations in place that test for all those same things. And we protect consumers by ensuring that same testing. And then we test the outcomes through high quality, rigorous study designs to see what the outcomes are of that use. I think that's going to be, like, in my mind, that's the way of the future of how I'd like to see things proceed. And honestly, rescheduling will not change that. You and then you.
I appreciate the work that you're doing in that, because you are a part of the population that this society values. And so they're gonna hear you differently than they hear me. So I thank you for your bravery in that. I live in a senior building. It is in my lease that I cannot smoke marijuana even if it's medical. So there's some barriers to this thing. So I really appreciate the work that you're doing. And
Thank you so much. The comment was about appreciation for the work, and I feel so honored by that. The one thing I will say is that smoking is not the only way that you can ingest cannabis. So as I mentioned, edibles, topicals, tinctures, these are all ways that don't generate that concern with, like, oftentimes it's like a public nuisance concern of smoke in a building. And then also people have concerns about getting high. So it's possible to, like, use a topical product that contains CBD. It will not get you high. Nobody will know that you use it. It will not generate a smell that that causes that applies to that potential concern. So just to put that out there. Yes. Yep. Yes.
So I am a cancer patient. So when I go into the dispensary with my medical card, I notice lately that you go, they tell you it's not a difference. So how would I know? I guess I just assumed that medical grade would be better than now that they have recreational. And then my second part is, I've been hearing one of the things about CBD, but someone told me it has to build up in your system to notice anything, but it's so expensive. But you know, so I guess a lot of people.
Yeah, so let me make sure I get this right. So the first question is, when you go in with a medical card, are you saying the staff say that there's no difference between the medical and the adult use products? Yep, it was just medical in the beginning.
Tested or whatever, then it was a medical side and a recreational side. Now it's just adult or recreational. But if you go in with your card, it used to be, they would say, well, you have to go over there, those are medical. They're better than, not me speaking mostly on edibles, because I never learned how to smoke, unfortunately. But, so.
And are you saying it's not that way now? Okay. Okay, so the question was about the difference between the medical and the adult use products, and how initially it seemed like when there's the split between medical and adult use, that there was some discernment between the products. What I've been told is that those medical products do have somewhat more stringent testing measures associated with them. But there's also some dispensaries that are solely adult use. So knowing if they have both a dual medical and adult use license might affect, so that it can be important to do the homework of apparently also the legal term is provisioning center for medical, whether the provisioning center or the retailer, what kind of licensure they have. And to the second part about CBD, the question was, do you have to let it build up in your system to see an effect? And I think there's a growing body of evidence suggesting that it probably just depends on the context. So for somebody who is taking it for the anti-anxiety effects, because there's been some studies showing that, it can reduce anxiety in public speaking tasks or social anxiety, that's different than if, say, somebody's taking it for systemic inflammation. And so I would suspect, and that, like, for the systemic inflammation, perhaps it would take time to really do something to that, because inflammation takes a long time to build up and dial down. It's not something that you flick a switch on. While, feeling of anxiety that's triggered by a public speaking task, that is something that is more transient. So I suspect it has more to do with that context. Yeah, time for one last question.
I wanted to be in one of the studies, but I'm also in a couple of other research projects. So, type of pharmaceutical or anything that I'm taking. But I couldn't be in it because I was in another study. Is there room for me to participate in other cannabis studies and feel like I'm like in a Alzheimer's research study in the MyVet and that's like
Yeah, so the question was about, if participating in other research studies, is it possible to join these existing studies? And, so one of the things that's complicated about, these studies is and the researchers on the other team on any other team who's doing a clinical trial will tell you the same thing is, we really want to know if our study is having an effect on you. So for example, say you were doing a clinical trial for pain with fish oil, and then you wanted to join the CBD or another behavioral intervention or anything like, okay, I'm getting some kind of, like CBT or something like that, or anything of that nature. The people in that initial study will say, well, we want to know if this intervention that we're doing, if that's actually having an effect on you. And if you join one of these other studies, then we won't know which thing is causing that effect. Yeah, and including when you're in the follow-up phase, when they might be tracking outcomes and they want to understand, like, okay, well, what is the persistence of this effect of this treatment that you already took? And so what I'd say in that situation is, making sure that, when that time period is done with those studies that you've committed to. And at that point, then you can definitely contact us and we would welcome your participation. We just want to make sure we're not screwing up somebody else's data, because, and for you to fully be able to participate in the things that you've already decided. Obviously, it's your decision how you end up doing things, but this is pretty standard practice in researchers. People really prefer to have, folks only doing one study at a time because they want to make sure that then they're the most confident in their own data. And I know I'm at the end of my Q&A timeline, and actually food is here too, so we can all watch those munchies.
Great job. Thank you. All right, we're going to get started while you guys chew. That's fine. So our next speaker is Dr. DrewSturgeon. He's going to speak to us about brief pain reprocessing therapy study that was conducted in veterans. Drew is a fellowship trained licensed clinical psychologist and clinical assistant professor in the Department of Anesthesiology at the University of Michigan School of Medicine. And please welcome Dr. Sturgeon.
Hi, everybody. All right, so I'm going to talk to you actually not about a study that has been run. It's one that we're running in the near future. So I'll give you a little background on what this study is. And anybody's got any questions, we of course make sure we'll have time for that. I'm just going to start by saying a lot of what I would normally say to all of you was covered by Dr. Clifford's talk earlier. So I'm going to spare you from hearing the same exact thing a second time. So what we're going to talk about today is a new treatment that we're hoping to study for chronic low back pain. So just to start with, chronic low back pain is actually the single most common chronic pain condition in both civilians and veterans. It's the biggest cause of disability, of medical expenditure, and among active service members, it's the biggest cause of service separation. So people who can't continue in their military service, back pain is the single biggest reason. So when we say chronic, by the way, the term we use for chronic is 3 months or longer. There's a couple of reasons we use that definition. One is if your pain's been present for more than 3 months, whatever, if it's say it started with like a physical injury or an illness or something like that, the evidence actually says that beyond 3 months, where you might first give yourself a period of time to rest or recover and let the body heal, research actually says that if you keep resting and avoiding using it beyond 3 months, it doesn't actually help anymore. So you have to shift from understanding your pain as being caused by damage to maybe it being caused by a more complex set of things. So the other thing that we should probably point out is that when we're talking about chronic pain of any kind, but chronic low back pain is a good example of this, is that no single intervention actually consistently shows benefit. So you can take any treatment that exists and it will work pretty well for about a third of people. It might work a little bit or not at all in some people. And then there's another subset that maybe even get a little bit worse. And part of the reason for that probably is that even within the same pain condition, there's a lot of different things that could be happening that can cause it. So it might feel the same, but there's a lot of things, particularly in the chronic case, that suggest that maybe it's not just damage to the body anymore. So let's talk a little bit about pain itself and how we define it. And I'll be honest, I showed up late today, so some of this is a repetition. I'm sorry for that. So the way we define pain, the biggest pain research organization in the world is called the IASP, the International Association for the Study of Pain. And for about 40 years, they've said that pain is more than just a sensory signal. So in addition to knowing what kind of pain it is, that if you twist your ankle or burn your hand on a stove, there's different nerves that pick that up. It feels different, you know that's true, but there are also hardwired emotional components and cognitive components to pain. So pain isn't just that sensation, it's the emotion I get when I experience pain. And then this cognitive component is the idea that your pain teaches you something. If you were a kid and you put your hand on a hot stove, that's a useful lesson. After you burn your hand the first time, you generally don't do it again. But in the case of chronic pain, sometimes it teaches you to do things that are actually healthy for you. Like if I exercise, my back hurts for a week afterwards, then maybe I don't try and exercise as much anymore. So all of these things are a fundamental part of the pain process. And I'll even add here, so you see at the bottom of that list, social elements of pain as of 2020 have actually been added to the definition of pain, meaning that it's not just what's happening in your brain and your body. The stuff happening outside of you also modifies pain. So external stressors, trauma, social support can reduce pain. Even more broader things like somebody's experience of poverty or homelessness actually affects how they experience pain and then how it gets treated. So it's a very broad definition of pain that we use. Now, I referred to acute and chronic pain a little bit earlier, but just to give you that basic definition, acute pain, pain that occurs right as something damages the body, is really useful. We need to know if something's damaged so that we can protect it. But if we have chronic pain, it gets beyond that first 3 months. It tends to mean that the body is done healing, at least doing so on its own, and you have to think differently about it. Now, what comes with that is if people shift from an acute pain to a chronic pain state, there's actually some research that says your brain is doing something different in the chronic case than it is in the acute case. So there's a much bigger involvement of learning, memory, and emotion circuitry in chronic pain. So if you have a new injury, something you burn your hand on a stove, the parts of your brain that light up are related to sensation and attention. You need to know that you injured something and you need to know to pay attention to it to keep it from getting worse. That makes sense, right? In the chronic case, those parts are active, but it also starts involving this learning and memory and emotion circuitry, which means it's not just what your nerves are saying right now. It might also be that the brain's factoring in all the prior times that your back's been in danger. So it's sounding this alarm, even if it isn't an immediate current threat. Does that make sense to everybody? No less real, by the way. The pain is exactly the same, but it's being driven by something other than what the tissues are immediately saying. So, can't read my own writing. I will say what comes with this, especially in the chronic case, when we look at large scale research, there's actually a pretty weak relationship between what we see on somebody's X-ray or their MRI and how much pain they have. And that works in both directions. So you can have a ton of structural problems and actually not have a lot of pain. And some people report a ton of pain and we look at their x-ray of their MRI and they don't have any structural problems. I want to be clear, that doesn't mean that the health of your body doesn't matter. It of course does, but especially in the chronic pain case, it's way more complicated. I sometimes use the analogy of like baking a cake, right? Looking at somebody's x-ray and predicting how much pain they have is kind of like trying to look at a bag of flour and know how the cake's going to taste. There's a lot more that goes on. And it turns out, somebody pointed out to me, you can bake cake without flour. So I know I didn't do that one on purpose, but I'll take it. So I want to highlight here a really important idea with chronic pain, which is that pain can continue even if the body has fully healed from an injury or from damage. All right. And it happens actually in a lot of cases. When people have chronic conditions, say it's caused by arthritis, it's caused by lupus, it's caused by a condition where there might actually be bodily changes, even in between, even when there isn't immediate change in, say, inflammation or other things, the brain sometimes still sounds this alarm. And there's a lot of chronic pain that we think that goes this way. So the estimate is that in chronic back pain, maybe about 70% to 80% of people have some component of this where the brain might be sounding the alarm, even though there isn't immediate damage that would explain why. So we think it's super common. I will acknowledge this is a very understudied part of chronic pain still. Our lab in Ann Arbor does some of this, but there's a lot of research that's emerging out of this. It's not unique to back pain, but back pain is a good example of it. So the key takeaway from this is if you've got chronic pain, at baseline, what we're thinking probably is true is that the pain is no less real than if you had acute pain, but that your brain's probably protecting you more than you need. That signal is it could be even at a very high level, but probably not what you actually need to keep your body safe. You know, people will report being at an 8 or a 9 or a 10 out of 10, even though there's no indication that they're damaged, even though there isn't immediately any damage. So for example, if anybody's got pain when they're not moving, why would your brain be sounding that alarm if there's no damage being done? This comes up a lot. And I want to be clear, this is a very common thing that happens in chronic pain. It's not something people do to themselves. It's not a choice. It's not all in the head other than the fact that the brain's in the head. This is a very common problem. So I use the analogy sometimes of the brain being like a microphone. All right. So if you have acute pain, that's the microphone doing what it's supposed to do. So if I'm talking and you can't hear me, then the microphone's not working. So there are some people that are born without the ability to feel pain. They don't tend to live past childhood because they can't tell when something's wrong with the body. So acute pain should sound that alarm if I've got a broken bone or if I'm leaning on something that's bad for me. That's the alarm. That's the microphone working the way it's supposed to. Chronic pain, it might mean that your microphone is oversensitive. All right, so everybody here, we're all kind of post-COVID now. Everybody here is familiar with Zoom and how that works. Anybody here ever had, say, a Zoom session with somebody where the microphone was way too sensitive? You didn't just hear them talking, but you can hear them moving around in the chair or, you know, somebody in the hallway behind them. Those sounds are real, right? But a good microphone filters them out, right? You don't need to hear that if you're on a Zoom call. So sometimes the way to think about chronic pain, because the question that we get a lot when we talk about chronic pain is, well, my doctor said I have a structural problem. But there are some structural problems that don't actually mean that your body's in danger. They can be stable, right? But the microphone picks it up anyway. The brain's saying, this is a problem, even though it isn't actually. Does that make sense? No less real, but again, the brain's kind of overprotecting you. I put this model in here. I'm not sure how important it is to all of you, but let's just talk through this briefly. Basic model, if somebody has a new injury, is there's a trap that many people fall into in the period of time after an injury. So as their body heals after an injury, what people sometimes do is they experience pain and then they have an intense fearful response to it. And that fear drives them to stop doing things that might otherwise help them get better. So if I throw my back out or I break my leg, in that period of time after the tissues heal, I need to use my body again in order to get better. But sometimes the pain is so intense that it scares me off and I stop walking on it, I stop bending, I stop lifting. And the more I do that, the weaker my body gets and the more sensitized my brain gets. So it sounds that alarm, and the more I avoid, the weaker I get and the worse the pain gets. So it feeds back into itself. Okay, so this is about a 40-year-old model. A lot of these terms, I don't know that I ever say to somebody that they have negative affectivity. That's not a good way to make friends. But does that model make sense? So that's a risk for a lot of people when they have a new injury, and chronic pain can fuel itself like this for years. So the way that a lot of people in fact get better is the right side of this picture, where you see even as pain shows up, you get the fear and that avoiding movement under control, the body gets stronger, the brain gets calmer, and pain goes down. So that's the basic model. If you want to know why we talk about physical therapy for chronic pain, why we talk about exercise for chronic pain, this is why. And these are not new ideas. Like I said, this model is actually older than I am. Thank you for laughing at that, whoever did. All right. So I covered some of this already, and this is not unique to chronic low back pain either, but best practices for chronic pain are retraining of the body and the nervous system. It might mean, if you're deconditioned, getting your body stronger, getting your body more flexible, building your endurance, but it also means calming down the nervous system because it might be overprotecting you. So when we talk about, Dr. Clifford talked about this in her talk earlier, it's multimodal or it's multidisciplinary, right? We don't say, well, you just take a med and you're going to get better, because there's a whole lot of different stuff that the body and brain are doing, and they might need different treatments. So it might include medical treatments, it might include physical therapy or exercise, and it might include psychological or behavioral treatments. I want to be clear, when we're talking about psychological behavioral treatments, that is not to replace your medical care or anything else. It's a complement to it, right? I will say my pitch, I know there's been a lot of discussion about opioids. As a pain psychologist, I'm very neutral on medication. If people say it helps, great. They say it doesn't help and they don't want to take it, great. My job is to try and make the medication less necessary. If we can get you feeling better and you don't need the med, I don't know who complains about that. So I will point out, even though these behavioral or psychological treatments for pain have existed for about 40 years, almost nobody uses them. There was a large nationwide survey done in 2016, and only about 4% of people with chronic low back pain ever see a behavioral provider, a psychological provider for pain management. So this is super, super, super rare, even though the research is very, very well developed. And by the way, we don't necessarily know that what the rates are in veterans. It's probably not quite that low because the VA has better presence. So Dr. Clifford mentioned she's got 2 other pain psychologist colleagues in Ann Arbor, but that's still it's still a low rate. So I'll just talk about this study in particular. This is the basis for our current study. So there was a study published about 2 years ago out of Boulder, Colorado, for this new treatment called pain reprocessing therapy. And it's based on this idea that I've been talking to you all about, that pain is occurring because the brain is overprotective. It's sounding this alarm. And basically the idea is, if we can teach the brain safety, we can teach the brain that the body is safe, we can get pain to decrease. So they enrolled, this was all civilians, has not yet been done in veterans. That study's actually starting up soon. But they did a combination of gentle exposure, say through meditation or small amounts of movement, paired with a lot of education about how pain actually works. And at the end of this, so they had 50 people in this arm at about a 4 out of 10 pain. So not a lot, but enough that you'd say it's chronic. At the end of the study, 2/3 of them had either no pain or 1 out of 10 pain, and that stayed for a year. So we don't actually have any clinical trial that looks like this, where 2/3 of people at the end basically say, no, like I'm done with chronic pain. I don't have any pain at all. So it made a lot of waves. There are a million questions about how generalizable this is to everybody else. If that's what you're thinking, you're on the right track. But among some people, you can basically get them either all the way to 0 pain or almost all the way to 0 pain by teaching the brain safety. So as I said, this has never been done in veterans. That study is starting up in Eastern Colorado in the next 6 months. We're also going to talk about the current study. So one of the big problems and why people don't tend to see pain psychologists very often is because it's a pain in the butt to see them. Our existing treatments, that was not meant to be a pun, but here we are. I haven't eaten yet, just blame low blood sugar. most of our treatments for chronic pain run 8 to 12 sessions, 1 session a week. For years, it was all in person, and asking people to do that when they're busy, when they don't feel good, when they've got caregiving, when they've got all these other things going on, it's just impossible. We set people up for failure. So there's been a big push, especially since COVID, to make our treatments shorter and easier to access. So the study that I got funded, that we're starting recruitment for in the next month or so, is going to be to test this same treatment, this pain reprocessing therapy, in a briefer and Zoom-based format. So the pitch is, can we see the same effects doing 3 sessions instead of 8, all over Zoom? So we're going to deliver the same model. I see some skeptical looks. That's great, no problem. We have actually already running this in civilians with fibromyalgia, and we're seeing some good results. So at the very least, people are willing to try it out. The idea is we'll schedule 3 Zoom sessions. You have to do some early questionnaires, and we do about 35 days of daily diaries just to get a sense of how your pain and your mood and your other things are responding during the treatment period. But you never actually have to come to U of M. You never actually have to show up for any sort of in-person appointment. And we're hoping to get 40 veterans with chronic low back pain to join us for this study. So what it looks like is you have the 3 Zoom sessions. It'll almost certainly be with me. So if you're tired of me already, this might not be the study for you. But if we get the chance, we'll roll it out to others as well. And there's some pre-recorded meditations and other exercises that you use. We send you some handouts. And then at the end of the 3 weeks, we just see how you do. So that is what I had for you. Thank you all for paying attention and for laughing at my dumb jokes. Yeah. Uh-huh. I'm sorry. Okay, all right. The question, all right. The question was not quite a, well, there was a question in there. You had me at Zoom, where do I sign up? So we will actually push our, there's a monthly, there's an update email that the team will send out, and we'll actually put our study email in there. We just got approval from the DoD to start about 5 days ago. So we are ahead of schedule on that, but the strong likelihood is it'll be sometime within the next 2 to 4 weeks. So once you get that email, you'll see our study email address on there. Just email us and we'll get you, as soon as we're up and rolling, we'll contact you.
But a veteran I worked with who since passed was a WMT above the knee, and his issue was phantom pain.
Yep.
So would this be something also that could work? He actually found acupuncture was the only thing that ever helped him, but in this situation, the brain was still firing.
Yep.
Saying his foot hurt, but he didn't have a foot.
Right. That's actually in the treatment, by the way, that the idea of phantom limb pain. So yeah.
So would this tie into something like that, someone in that situation? Not as lower back, but
yeah. So that's a great question. So the question was, so referencing the fact that some people with phantom limb pain, for example, have pain even though the body part is absent. Would this work for that? I think it probably could. Now there's some complexities around that. Sometimes depending on how the amputation happened, there might still be nerve activity where the amputation occurred. But a lot of the treatments we use for phantom limb actually look like this, where you're teaching the brain stuff using like a mirror or imagery or other things. So don't quote me on this, but I think it probably has an effect for at least a subset of people with phantom limb pain. Yeah.
With my background, when they started, they were real sad because my house was bad. I had contact, everybody was short. I wanted to be short. So I never held my shoulders back on my heart. Then I was taking care of the veteran, and my stupid brain told me to help this man get out the bathtub because he was so easy to me. When to pull him out, I heard my back when it cracked. I was like, nah, I'm gonna be not changing that. So then I went to the doctor begging for drugs because I'm all messed up. And luckily, he just gave me medicine, my painkillers, so he get off my foot. To add injury, I was carrying this 5-gallon thing of water up the steps after I had already cracked the back. But the brain, like you said, if you listen to your body, so I listened to my body and sort of started to heal myself. And once I stopped just being lazy and getting up and being motivated to move, work out, and exercise, and swim, and gym, and all that good stuff, no more like that. No more walkers.
All right. I don't know that I can repeat that whole excellent story for everybody who's on Zoom, but let me just say that was That was phenomenal. That's exactly what pain recovery is supposed to sound like. It started with having back pain. You were helping somebody get up. You heard your back crack. You heard the injury, and then there were some repeated injuries after that. But once you kind of slowed down, you let it heal, and then you rehabbed yourself, it got all the way better. That's what's supposed to happen. Congratulations to you. Yeah. I think I saw one more hand up.
We're hypervigilant,
Uh-huh.
always on, right? So does this help us to dial down? Does that? Okay.
So the question was, knowing that a lot of veterans have learned to be hypervigilant, learned to be kind of overprotective for other reasons. There probably is some overlap of what the folks that were running this right now in fibromyalgia, about a third of them, we get through the information part of it. They're like, this is about my trauma, isn't it? Which is not what this is. This is not specifically a trauma treatment, because a lot of people get this chronic pain even though they don't necessarily have that trauma. The brain can get overprotective for other reasons. Now, in my clinical practice, I would say people with pain and PTSD, or at least some of the symptoms, report benefit from these, because this idea of safety, there's a big overlap between chronic pain and PTSD. The brain just can't tell the difference between when you're safe and when you're not, and you got to actively train it. So I think it probably does. We won't have quite enough data to answer it with this study, but when we're recruiting, by the way, we're not screening out if you have based on your meds. We're not screening out based on whether you have PTSD or not. If you got a back fracture, this is probably a different treatment than what we're going to give you if you're in that chronic pain phase is what we're after. Did I answer your question? Yeah.
Time for one more question. I'm so sorry.
Yeah.
But we have one on Zoom. So is there such thing as central nervous system chronic pain? And if there is, how would you treat it?
Yes, it absolutely does exist. The term we now use is nociplastic pain. So it's generated primarily by the brain and the nervous system. Fibromyalgia is an example, but we actually think people can get it. They might even start, say, with tissue damage. And then after that tissue damage heals, the brain just keeps sounding that alarm anyway. There's even a great story about it's not a great story. Psychologists aren't that fun at parties. Like having chronic bladder issues, having your bladder removed, and even though it's completely gone, people report pain in the bladder or feeling a full bladder that they no longer have. So the brain can overprotect just because that medical symptom occurs over and over and over and over again. So it's got to be driven by the nervous system, right? Because there's no bladder anymore. Kind of like the phantom limb exam.
And how do you treat?
How you treat it is with treatments like this. So the idea is you teach the nervous system safety. It's about paying attention to it. It's about actively challenging it, not unlike the story you told about using physical activity. Physical activity is another exposure treatment, right? You're asking your brain to get used to something that it's currently scared of. Ideally, you're doing it in small doses so that it doesn't freak out and lock up on you. Thank you.
Thank you so much.
So originally we had a break scheduled for this time, but our breaks have been rearranged. So we are just going to set up quickly for our panelists and just continue with that. And so yeah, we're getting close to the end. Okay.
Thank you so much for being here. I just have a few questions to really facilitate more of, your story and what you're able to share with everyone today. So just to get started, I'd like our panelists to share your name, what brought you here today, and why you're willing to share your story.
Hi, everybody. My name's John Stevens. I was a Marine for about 13 years. I was medically retired in 2015. I want to share my story today because I've been a chronic pain patient for about 10 years. Today, I'm very much not in pain. I still have my bad days, but it's not anywhere near what it was. And also, we've talked a lot about opiates today too. And I was involved in before the opioid crackdown. I was one of the statistics of the veterans being injured and getting hooked on pain meds. So I can speak to that as well. So hopefully my story has some value for you guys today.
My name is Stuart Jacobson. I was a paratrooper in the U.S. Army back in the 80s and didn't realize for a couple of years that over the years I had these pains. By mid-40s, I experienced sharp pains in my back and went to the VA, and they discovered that compression over these landings falls basically had caused it and eventually became connected there. So tried all kinds of treatments to kind of bring the pain down and nothing really works. So I've been still on that journey, even to this day. And then on top of that, I had cancer last year and everything else. So it's blown up into some interesting things. So all this, I want to basically share my experiences as far as going through all these treatments and seeking solutions so that everything that I've learned, which I've learned from people just like you here and other veterans on the street and other organizations like this wonderful one that's exploring how to resolve this huge problem. I'd like to, of course, give away, share in any which way to improve anyone's life, including veterans and everyone else.
Thank you. We've talked a bit about how communicating with healthcare providers is a big part of managing pain symptoms. And I was just wondering, what has your experience been with communication with your providers around your pain care? And how do you have any suggestions about building an effective care team?
Want to go for that one first?
Okay. Here. So I think it's a pretty complicated question, but I try to, given the limited amount of information we know when we're younger about all this sort of stuff in the first place, and all of a sudden you get it or some kind of injury, and hopefully you're side by side with a great provider like I did in Los Angeles, Dr. Kashefi. Loved him. He was there for me. Anything I brought up, he tried to find some solutions. So I think that's important. Here I also have a Dr. Patel, so I give them two credit. I give everyone credit, but those two really, really embrace getting alongside. So that is, I believe, probably the most important thing, and then educating yourself so that you can communicate with them and then they can understand what you're going through and find you the solutions, or if not, suggest.
I think building an effective care team, I think it's on what I've learned in the last 10 years, it's on the veteran to educate themselves and take ownership of your own pain problems. If you're relying on doctors, especially with the opioid crisis, just to give you an idea, like I've had a pain issue in probably about 5 years, but my medical record coming out of the military is horrific as far as on and off pain medications with substance abuse. And I went in for a neck pain, and then within the first 3 minutes of having that appointment at the VA, they already told me that, hey, opioids are off the table. I wasn't going there looking for opioids. So it's kind of like they went through my profile, saw that there was seeking behavior from 10 years ago, and I was still having an issue with that. And then it was kind of like I got met with resistance there. So, so with that being said, I would say, yeah, taking ownership of your own pain thing, doing your own education. And I like the fact that today we're talking about reframing your idea of what pain is, because that's really, for the most part, the answer. That's one thing I've learned going through all this entire process was once you start to reframe your relationship with pain, it starts to go away after time. But we're taught a lot to, instead of looking internally, we kind of look for external things to kind of help us in there. So yeah, I'm happy that we're talking about other routes. So.
Chronic pain and mental health symptoms both can be very unpredictable. One day you may feel fantastic, another day you may have taken more on than you should have in hindsight. I'm curious about how do you approach pacing yourself, especially when it means maybe missing out on things that you were planning on?
Yeah, it's interesting. It's been a learning curve. So like you said, things happen. And for example, I rolled over on my yoga mat 4 months ago. Next thing you know, I fractured a rib. But then that could have been caused because of the low density, bone density I have, from cancer treatment. So you don't really know when the next punch in the face or punch in the gut is going to come. And that being said, you just have to figure out a plan and set your goals. And for example, for me, I couldn't do any heavy lifting. So I had to the only thing I could really do was take long walks. And that was pretty much the only exercise I could get until I can get to the point where 2 months later, it should be okay. I took calcium pills and things like that. So that's just one example. So I think that applies all throughout, especially if you have a lot of experiences with ups and downs, which I believe all of you have, and just working through it by setting goals and proper nutrition, sleep, exercise, and then mental health care.
Yeah, I'll echo that too. As far as pacing yourself, just being realistic where you're at with your pain, and then I say what really changed it for me was I had multiple doctors how bad my injury was, and I was lucky to be on my feet. I walked for about a year with assistance devices to get back on my feet, but I was told for a year that like this is the best you're gonna get. I took kind of risk in my own hand. I do an exercise physiologist that I went to and lived with for about a year in Virginia. And the simple fact that once I was able to lunge and I got some of my physical ability back, my pain response changed overnight almost. I went from barely to get off the couch on scheduled opioids to almost having a zero pain response. So, but that took a lot of work to get there. It took a lot of psychological work to get there to understand my relationship with pain. So pacing yourself, you got to have a realistic idea of like what your pain's at. And then you can kind of build off there. If you still have the mindset that like you need these external pain meds and you're always in pain, you're limited due to your pain, I think there's not really a starting point there. So.
We've talked about dozens of treatments today for chronic pain, and you've shared just how much effort it takes as an individual, saying, it's on the veteran to be educated about their pain. And that can be a huge burden to take on at times. It can be stressful. And I'm just curious, how do you maybe cope on those days when it feels more stressful, it feels like more of a burden? What types of resources have been helpful for your mental well-being across this? It is a long journey.
You, John.
You go over the question one more time?
Yeah.
I lost it, sorry.
Yeah, no worries. Just, what are some of the resources or supports that you have found most helpful for your mental well-being?
For veterans, it's going to be other veterans. I'd say that's the biggest help, and yet a lot of people have like stories coming out of it. So I would say that's what I'm using today. Have you got something on that?
Well, I think for me, during cancer, I had to be isolated because my doctor said so, in order not to compound any other problems with other colds or flus or COVID, 19. But so that's not good because we're social beings. And so after a while, just like chronic pain, your body gets allergic to going outside and engaging. So engaging, I've always engaged with organizations. I learn about things, about how to deal with chronic pain. And so now that I'm feeling much better, I'm trying to force myself to engage. And lo and behold, I have so much more energy, more time, and therefore I could do that. But as far as trying to deal with all these things, I try to immerse myself in books, engage in organizations and advisory boards, which I discovered this type of meeting setting and agendas that address chronic pain. So I think and recommend to you all that if you have something that you're suffering from, please engage with groups or individuals who are specializing in it to treat it and solve it. So I think that's a partial answer to that long question. Audiobooks, books, all this sort of stuff. I'm always, and just paying attention and listening. For example, I heard Jimmy Kimmel talk about this whole thing, pain reprocessing therapy on the Oscars or something like this. And I caught that. So paying attention to what people say about something that you're experiencing, hey, and grab them. And you'd be surprised people will share.
Yeah. I think what we talked about today with the pain reprocessing thing, that's going to take a while in the veteran community for them to understand that there's a pain reprocessing thing. It's not just a pill that you take and then you work through your pain. The lessons that were presented today is basically what I learned over 10 years. It was just I just have to change how I think about and how my relationship with pain. I think that's the right answer. So.
I also want to acknowledge that sometimes clinicians and the public don't appreciate or understand veterans' unique lived experiences or health concerns. It may lead to them being dismissed or misunderstood. This question, I guess, is twofold, but just, is that something you've experienced in your journey? And if someone else is going through that, do you have any advice for them?
As far as I can tell you is that being familiar with what you're going through really helps so you can communicate that. Because most of the doctors are looking for what hurts, what's wrong with you, and therefore they can take it from there and go about it. So unfortunately, we're not prepared for what's going to happen to you tomorrow. So I don't know. just know something's going to happen to you tomorrow. Now, what are the most important things to learn about maybe as you age? The four main diseases and things like that, but you could start earlier. So I think, preventing these things and learning prevention probably is best for you. Therefore, by the time you get to the part where something does break, you'll be able to at least explain things that are really important enough for then their action could be taken. But I guess in the sense of dealing with the VA, if they can't address it right away, I've had that problem, and then they send you to community care, but there's a real huge time lag before you get there. And then at the same time, there's issues about billing and all this sort of stuff. And it gets to the point where you're like, wait a minute, you sent me over here. Now I got all this administrative issues where they're trying to get paid, and then they're trying to go through you. I'm like, I'm not even, what do I have to do to this? I'm not even involved. I'm just a patient. And so that is kind of frustrating and brings on burdens and stress on you and stuff like this. But more importantly, trying to get to and address the thing could be a problem depending on the availability of doctors and therapists at the VA.
Yeah, I've seen this change over a few years. So when I lived in Houston, it was like 2015, 16, the opioid crisis is in full effect, and we haven't had the crackdown yet. The doctors are starting to realize what was going on. And then, yeah, I've definitely been misunderstood and stigmatized multiple times just due to my background when they look at my stuff. But I feel like it's getting a lot better these days. Yeah, the appointment I had recently, I think is just kind of a one-off, but it was just kind of reminding me of the old days of like beforehand. So hopefully that's starting to go away. But I do feel like things are getting better, especially when you got people like this or starting to make programs, kind of retrain your brain and to getting away from the opiates.
We've talked a lot about cannabis-based therapies today, both from the research perspective. We've heard from a policymaker, and certainly in Michigan, it's a state where these products are legal for medicinal use if people choose to try them for pain management. And I'm just curious if either of you have thoughts that you want to share on additional ways that researchers or policymakers should be thinking about cannabis in the context of the veteran community, and kind of what more do you want to see?
It's hard to say because I mean the world I live in, because it's for military and then the public service and stuff. So my biggest thing is working in public services, especially in EMS. It mirrors the suicide rate that the veterans have. It's almost about the same, But the access to some of these things are obviously the access to psychedelics and access to cannabis is kind of off the table for these groups. So I think what we've all listened to today about these other resources, especially with cannabis, is like it's a scheduling problem, and that's not going to go away until that changes. Other than so that it's hard to say. Yeah, that's the biggest barrier to some of these helpful products.
I think again, it boils down to education, promoting it, and making sure everybody understands where we are and what's available, and then there could be some kind of voice for assisting to navigate through these barriers. Perhaps I'm thinking out loud, so I don't know. I'm not an expert at it, but I think it just seems like there's always, like Dr. Boehnke said, we're just not educated. I mean, there's just so much to be educated about now, unless you're in having these kinds of problems. Then I think that's probably your biggest ally, is to be educated or get education. So maybe create classes or even more workshops like this, specifically targeting and drawing in more participation.
Yeah, thank you. I have one last question before we open it up for questions. And I'm just curious if you have any thoughts for someone who's maybe earlier on in their journey, maybe recently experiencing chronic pain, maybe feeling hopeless in that circumstance, maybe something you wish you had heard or known about sooner.
Yeah, it's going to be, don't stick just to the medical model, don't stick just to the VA. You need like a wide range of people and things you got to, yeah, it comes down to education again. If you just stick with the medical model and expect to get to change and get better over time, there's so much more information out there that's not going to happen. I mean, there's a lot of things moving with the VA, a lot of studies going on. I think it looks very bright for the future for some of this stuff, but you got to do your own research. Look at what's working for other people, talk to your friends and see what there's tons of alternative treatments out there. Yeah,
I wish I had like a plan where I could say, you just follow this or go down this list and this will help you out. Don't worry about the VA, but it's a very hard task where you're gonna have to do a lot of this work all by yourself. And then that's gonna be your best, you're gonna be your best advocate for whatever you got going on.
I think the best thing you can do is just put out your issue to the public or to the universe. For example, a friend of mine came up to me and said, "Oh, I was suffering from a roof leak during terrible rainstorms, and they had black mold in their house." So I grabbed the microphone in my church because we have the ability to voice, prayers and these sorts of things. I explained to the church, and next thing you know, I had 3 people that came out and said, I have a place for them to stay, and yada, yada, yada. So applying that rule of thumb, I've gone out and just had conversations on the street, on the bus or whatever. And, we all do it. And next thing you know, just talking about a subject invites the opportunity for someone to share. And lo and behold, that person that you don't even know knows something that you want to know. I all the time. So I always try to create a conversation that's better than just hi and goodbye, at all times. But I think I would tell anybody that's the way to do it. Just be persistent and just put it out there, and the answer will come back, or somebody will point you in the right direction.
It's just not an easy task, right? Because the entire time you're doing this, you're maintaining your hope and you're advocating for yourself. It can seem like nobody cares about you whatsoever. So this is not an easy task to do by any means, and there's no real good answer for this. But yeah, just stay the course, keep trying, keep looking, and hopefully find something. So.
Any questions for our panelists? Yes.
First, appreciate you being here and participating, in the panel here. But this question, first one I have is for John. You mentioned about the veterans groups that they were helpful for you. Is there any in particular that you felt that might be more beneficial? And I don't know what they are. I've been retired for a couple of years. I'm not tied to any of them. My kind of in my head, I want to hear the war stories over and over a beer at the EFW. And I don't know where to find these groups. And if you found something that's useful like that, I'd really like to.
There's a lot of groups out there. You look at for what kind of resources?
Well, you're saying it's essentially in this theme of things, or figuring this out in the painting, or medical resources or whatever. You just mentioned that group was beneficial to you.
Yeah. I might not be the best person to ask this because a lot of my recovery came in through psychedelics. Went through psychedelic assisted therapy quite some time ago. That change in perspective has helped me out tremendously. And then that perspective change has got me into acupuncture, meditation, yoga, all the other things we talked about to manage pain. And there's a gigantic community that goes along with that that's full of veterans. So that was kind of, I know that can see it's a new topic and people are kind of making their decisions about it, but that has really helped me with that community because it's kind of forced me to do all the things that these places are talking about to kind of change your relationship with pain. So kind of fell into that process, not really knowing that there was a whole bunch of studying going on about it. Yeah, so it was kind of a happy accident.
Well, second part,
yeah,
kind of rolled into that then is I've got different therapists that I work with, and I'm trying to help them. They want to work with veterans, and they haven't served. I'm just wondering if you've seen any difference or felt a difference, or had therapists or felt that they need to have served so that they can connect with you, or does that matter to you at all if you've seen it there?
Yeah. So I've definitely had therapists that have not worked with veterans before, and it's a tough hour sitting with them. There's not really a way to relate. And then especially if you're not relating to them, then in your brain, it's just whatever they're going to say is not going to land with you. That's not to say that all of them are like that, because I think a well-trained therapist that's cross-trained with veterans that has a veteran in front of them, they do just fine. It's an education part of it too. I think if they're education trained and they have quite a few clinical hours with veterans, they're going to understand kind of the process and kind of that where their headspace is at versus. So it doesn't have to be a veteran on veteran, but I think there's some training and some experience that needs to go in before they start taking veteran clients. Yeah.
Any other questions? Yes.
Are there any advocate groups that can help veterans navigate through these programs, get more awareness?
Absolutely. Unfortunately, she's not here today. Carmencita she is great. If you want to know any kind of any kind of organization, she knows just about every organization that exists on the planet. So I'm not sure if you have access to her information, but she said she was going to be here, but she's not today. There's so many, but you can call the Michigan, I think the Veterans Affairs, and yep, and they can Veterans Affairs, and they could direct you to all the different. There's so many. That's the problem. Yeah. Carmencita. I know. I think she is aware of Carmencita or met her before. She was here at the last meeting. I remember you were both here. I could pass if you want. I could pass your name to her and then ask her to contact you. So we could do that. Yeah, she's always helping people, so she would be a great person to know.
Other questions?
Come on, come on. Good job, we got this right.
There's an American Chronic Pain Association. Do you know if there's an American Veteran Pain Association?
Whoa. I have not heard of that.
No, I'm not aware of that.
I was planning to go to the affiliate, but I thought that would be.
Well, ask Carmencita that same question too.
Yes, please.
So, two-part. I'll agree with you. Number one, no one's gonna look out for you like you. Some folks seem to think otherwise. So as a service officer, it's one of the things I had to overcome. But the other piece of that is the stigma that, okay, I'm not going to the VA because if I do, all they're gonna do is throw SSRIs at me, for example. We're gonna put you on Selexin and tell you have a nice day. How would you overcome that if someone is reluctant to go to the VA for the help that you got?
I was going to answer because I ran into that problem myself when I first applied for service-connected disability, and they said no because I didn't go to sick call when I, had several concussions. Probably, I don't know. I'm not a doctor. And then, like Regina mentioned, our culture is based on, I'm not gonna go unless my arm is broken or it's obvious, and so we don't go to sick call or whatever, and therefore there's no documentation. I think the younger generations have experienced more, have been educated to record and report to sick call and get this on the record. So therefore, if something does occur later on in life and it's tied to the service as a service injury, then they get qualified. So, but earlier generations, we didn't have that education. And I think that's what you're talking about. So I got a advocate, the Disabled American Veterans, and once I got them involved, and then things got a lot easier because they could kind of hold me by the hand and take me through and find all the benefits that apparently I was entitled to given my service.
Yeah. There's also a robust network of nonprofits that do that kind of work that people are tired of dealing with the VA. That can do that. So I don't have any off the top of my head. But yeah, I've used them quite a few times to keep myself out of the VA.
There's others too, like American Legion, Purple Hearts. In fact, one advocate for the Purple Heart, while I was just going to the VA hospital, he goes, "Come here, soldier." I go, "Yeah, you." I hate, I did that at jump school and I got in big trouble because I was walking. He says, "Come here, soldier." And I looked and he said, then, kind of punished me for that in walking on the drop zone. But anyway, everybody else was doing it. So I thought it was the right thing to do. So he said, "What were you doing in the service?" And I told him I was a parachutist, and "Oh, come right here." They started checking off all the injuries that I could possibly qualify for. I'm like, I don't even know what he's talking about. So, so that's another organization that could be a representative. And there's a few others, but for the most part, that's where I would go because most of us, unless maybe the earlier generations Or now, the generations now are more familiar on what to do, but us older, I'm nearly 60, so I'm 59. And I had no idea. I'm completely naive. You know,
To get the care that I actually needed, the VA was basically done with me. As soon as I could stand up and I could feed myself, they were done with the PT portion of it, and that wasn't good for me. I was still in a walker, and I've been an athlete my whole life, so I had a hard time with that. So I had to go work through a nonprofit. They had to raise money for me to send me to a place that was like like an inpatient physical rehab center that they paid for. And that's what made my turn. I had nothing to do with the VA. It was a veteran nonprofit that helped me. Funded about 20 grand for me to sit there for a month. And that's literally like what got me back on my feet and started me started to heal a little bit after that. So yeah, unfortunately, that's probably the quickest answer for that. Yeah.
Well, not to add to what you're saying, but in chronic pain care in general, sometimes the treatment does get siloed, especially if you're only going to primary care. But our speaker, Thiera Clifford, mentioned too, like asking specifically to see a pain psychologist, or if you're not happy with the pain care you're getting, going to get a second opinion or asking for a care coordinator. Those are resources a lot of people may not be aware that they have as they're getting rushed through a routine visit. And so kind of speaking up, I think, has also been successful for other people too. Any other questions? Any questions on Zoom? Let's get over
I was a parachuter too, and that's what hurt me. I broke my pelvis in like 6 places.
All my guys are broken.
I went into the trees and had a 20-foot fall. Yeah.
I used to do learning to go for hope, like my other food broken.
But I just want to give a reminder to the folks in the room that if you need your parking validated, make sure you let us know. So that we can actually like, okay. Thank you so much for being here and your patience throughout lunch and have food. But I won't have time, so we're good.
All right, we made it. As our conference comes to an end, I just want to say a big thank you to everyone attending, both in person, online. Thank you to our speakers for sharing your expertise, and thank you to those in the audience for your questions and comments. Everyone's enthusiasm really elevated the opportunity to learn from each other. A special thanks to those who shared your personal stories. Your courage and openness brings an essential perspective to advancing veteran health. So taking what we learned from today, let's keep moving forward towards better resources and treatments for veterans, safe travels home, and we look forward to seeing you again soon. Thank you.